starts.
Yeah, I know. You know, and I'm so thrilled to have Rajesh Sinha joining on.
Now 6:30, ma'am. We are in live.
Okay, fine. We'll talk about Rajesh later. A very, very, very warm welcome to one and all of you for our Eye Foundation initiative to have a webinar from every month, and it's experts and stalwarts and terrific guys like you, which would make each of these webinars successful. And truly, it's been nice that it has been well received and well attended, which keeps egging us on. So Dr. Merle has yet to join. Maybe our LV Prasad friends can inform her. She's in our OPD. I don't know. We would want her there.
She has OPD. I'm sure she would.
She said she would, and maybe she would have slipped her mind. So just, can you message her? So
yeah, I'll do that.
Yeah. And we're truly lucky to have Dr. Merle, who will be joining us soon, who's our network director of the LV Prasad Center and for finance and accounts, and an amazing cornea surgeon. We are very lucky to have with us Dr. Vanati, who is our own editor of IGO and also is a professor of ophthalmology of cornea, cataract, and refractive services from RP Center. And I know what is the kind of value this webinar is going to get added to with her around. And we are lucky to have with us our own Dr. Shrish Kumar, and who, you know, his name is synonymous to Eye Foundation because that's how he has been to us all the time. He's our own medical superintendent and an awesome, versatile surgeon who's there for all of us when we are in trouble. And he's in cornea, refractive, and cataract services. Joining us soon would be Dr. Som Sheela, who again is heads this awesome initiative of LV Prasad with Sun Pharma and having a huge hospital at Mumbai. And I know with her leadership skill, she's going to take it to a different level. We are very lucky to have with us Dr. Sunita Chaurasia, who's a senior consultant cornea, anterior segment and refractive services, and also medical director of the eye bank therein. And again, an amazing person, surgeon, academician, you name it all. What she talks is absolute sense. And moderating with me is my very old Dr. Shreyas Ramurthy, and he's been again a great asset to us. And thanks to Arvind and LV Prasad for making him what he is today. And he's a specialist of cornea, cataract, and refractive services at our center, and he's going to be doing the major share of moderating. So we go on to our first speaker, and we're lucky to have with us Dr. Anahita Kate, who's a consultant cornea and anterior segment, cataract, and laser vision correction from the LV Prasad Center at Hyderabad. And she's going to be talking on a very important topic, Mooren's ulcer, step ladder management. On to you. Hello, Dr. Vikas. Nice to see you here.
Good evening, everyone. I hope my screen is visible and I'm audible.
Yeah. Yes.
Okay. Thank you, Dr. Chitra, for the opportunity to present here today. So I will be discussing Mooren's ulcer in terms of its differentials and management. Basically, how do we approach a patient when we see a case of peripheral corneal involvement? So as we know, Mooren's ulcer is a disease which is usually limited to the elderly. When it does occur in young individuals, it tends to be more malignant, more aggressive. The symptoms the patients can present with severe ocular pain, photophobia, decreased vision. It usually starts in the periphery, and what is classically described, the patients will have an overhanging corneal edge, as is seen over here, with or without an associated corneal epithelial defect, and it's a peripheral ulceration. So when we see such patients, how do we approach? What are the differentials that we should consider? So broadly, these differentials can be classified as inflammatory disorders and degenerative corneal diseases. Within the inflammatory disorders, we primarily have peripheral ulcerative keratitis, which is very, very similar to Mooren's clinically. The difference is that there is an underlying connective tissue disorder in this patient. The other entities that can mimic Mooren's ulcer is microbial keratitis and marginal keratitis. Degenerative diseases, again, that can have a similar clinical presentation include Tyrion's marginal degeneration, pellucid marginal degeneration, senile degeneration, and a delay. So we'll look at each one of these entities individually. Like I said, a peripheral ulcerative keratitis can have a very similar picture with a peripheral corneal ulcer with an overhanging edge and epithelial defect. The main difference lies in the fact that the patient will have a positive report when you do the connective tissue disorder profile. This is a patient with marginal keratitis, and patients who have infective disorders can also present with a peripheral ulcer. And so it is important in all these patients, even when the clinical presentation may be very typical, but we have to carry out a corneal ulcer scraping to rule out any underlying infective keratitis. So this was a patient who presented with a very typical PUK-like picture, nearly crescentric infiltrate involving around 270 degrees of the cornea. And the patient had progressive ulceration, and on repeated scraping, the report was always negative. It was only when we did a therapeutic keratoplasty that we realized that the patient had Pythium. So doing a corneal scraping is absolutely imperative in these patients. So marginal keratitis is yet another differential. The main way to differentiate this is that it's the typical location that these patients will have where the lid margin comes in contact with the cornea. They will also have a clear interval between the lesion and the limbus. And usually the eye is quiet in these cases. This does not have any age predilection, unlike Mooren's ulcer. The other end of the spectrum, degenerative diseases, again, here the eye is very quiet. So that way you can differentiate these disorders from a peripheral ulcer, from a Mooren's ulcer. The most common one here is Stevens marginal degeneration, usually occurs in men at any age, and they present with decreased vision. PMCD is yet another differential. This is an ectatic disorder. Very rarely will have corneal scarring, and overall is not very difficult to differentiate this entity from Mooren's ulcer. And the other entities, just to complete the list, one is the senile marginal furrow degeneration. Again, the patient will present with a quiet eye, usually seen in the elderly. It is circumferential, and the patient will have an intact epithelium. And Delin is what we see when there is a localized conjunctival abnormality, which is causing tear film instability in the area adjacent to it. And this instability causes breakdown of the corneal epithelium with thinning of the underlying stroma. And the patient will have, again, an intact epithelium with pooling of the dye, as is seen in this picture. So to complete the differentials to be considered when a patient presents with a peripheral ulcer, this is a patient who presented with an inferior PUK-like picture. Here we can see there's a crescentric ulcer. So the patient was managed in the lines of a Mooren's ulcer, managed with topical steroids. Connective tissue disease profile was carried out, and it was negative. And the patient had a relatively uneventful course on therapy. However, after when the eye quietened, we again examined the fornices, and the patient had significant shortening, and the biopsy was positive for oculocicatrisal pemphigoid. So it is very important to also examine the fornices in all these patients to rule out any concurrent autoimmune disease. So this patient was managed with immunosuppression and did not have any further recurrences. So how do we approach a patient with Mooren's ulcer? When we see a patient with a typical picture of an overhanging corneal ulcer in the periphery with or without a corneal defect, like I said, the first and foremost thing that we need to do is to rule out underlying secondary infection with the appropriate microbiological workup. And we also do a complete systemic workup to rule out underlying connective tissue disorders. I will be coming to this in a bit. When it is indicative of an underlying disease such as rheumatoid arthritis or Wegener's, then in conjunction with the rheumatologist, the patient is started on immunosuppression. However, if it is negative, then based on the degree of involvement, we will either start the patient only on topical therapy or start the patient on systemic immunotherapy. So the investigations that we send out, we can broadly divide them based on two categories. One is to identify what is the underlying disease, and the three main tests that we do over here are rheumatoid factor, ANA, and ANCA. And the other tests we can simultaneously send out so that we can understand whether this patient can be started on immunosuppressive therapy or not. In our country, because tuberculosis is very endemic, it is absolutely important that we rule out underlying TB in these patients with MAN2 and chest X-ray. A viral screening with hepatitis B, HIV, these diseases should also be ruled out prior to starting the patient on immunosuppressive therapy. Along with this, CBC, RFT, and LFT to ensure that the other systemic parameters are normal. So coming to the medical management, like I said, this depends on what is the degree of involvement. When the patient has a unilateral disease of up to 2 quadrants of involvement with less than 50% of stromal loss, the patient is managed with only topical steroids. However, in cases with bilateral involvement, with more than 2 quadrants of peripheral corneal involvement or more than 50% stromal loss, the patient is started on oral steroids with immunomodulatory therapy. So the principle of giving both these medications is that immunomodulatory therapy, usually with methotrexate, azathioprine, or mycophenolate, all these medications take around 6 to 8 weeks for the effect to set in. And during this period, you will start the patient on oral steroids so that by the time the effect of those medications sets in that gap, the oral steroids will act. When the patient is one-eyed, or if the patient has extensive more than 3 quadrants of peripheral corneal involvement or more than 50% stromal loss or impending perforation, these patients, immediate immunosuppression is required with IV methylprednisolone or IV cyclophosphamide. So again, based on how severe the disease is, you will decide how frequently you want to follow up the patient. The more severe the disease, the more frequent the follow-up. In one-eyed patient, you want to follow up the patient daily until the epithelial defect or there is adequate resolution, after which you can follow up monthly and then 3 months. So now I will discuss this management with a few cases. So this was a 39-year-old lady who presented with redness and pain since a month. She had this kind of picture in the periphery with thinning from 4 o'clock to 8 o'clock with an overhanging edge and undermining of the base, superficial vascularization. Her visual acuity was fairly good. Because she only had unilateral involvement and it was limited to up to 2 quadrants, the patient was managed with topical steroids, and she did very well with this. This is the picture at the final follow-up, and the patient was not started on any systemic immunosuppression. CTD profile was carried out, and this was negative for any underlying disease. This is another patient who had bilateral involvement. We can see in this eye, the involvement is almost from 11 o'clock over here to 2 o'clock here. Similar picture in the other eye. So this patient was started on oral steroids and received IV methylprednisolone as well in view of the extensive bilateral involvement, along with IV cyclophosphamide. Concurrently, the patient was also started on oral methotrexate, and the patient did well. On 2 months later. This is a similar case. So the difference I wanted to highlight from the previous case and this case is that even though this patient had bilateral involvement, this was an elderly patient, he was managed only with oral steroids and oral methotrexate. So the degree of involvement that is seen over here is because of the chronic course of the disease. But this particular episode—
1 minute more.
Yes, this particular episode of the patient was relatively indolent. So this is the response that we noted with 1 week course of oral steroids, and over a period of time, the patient did very well. This is after 1 month of oral steroid, and the patient was maintained on oral methotrexate. So this is the last case. This is again a one-eyed patient. Because the patient was one-eyed, the patient was started on IV methylprednisolone and had very good resolution. And because of the corneal scarring, the patient, we did a optical PK with a broad tarsorrhaphy, and the patient maintained good vision until the last follow-up. This is nearly 4 years after the optical PK. Just a small note on managing perforations in patients with Mooren. Cyanoacrylate glue is the most commonly used modality. It is used for closing perforations less than 3 millimeter. For larger perforations, multi-layered AMG such as this is a very good option. Tennant's patch graft is another option that can be employed in these patients. Corneal patch grafts can also be carried out in the periphery. Later on, if there is significant astigmatism or significant scarring, the patient can be taken up for an optical PK. If the perforation is very large, the patient has to be subjected to a tectonic penetrating keratoplasty. So to summarize, in these patients, first we need to rule out an underlying systemic disease, a connective tissue disorder. We need to rule out a concurrent microbial keratitis. Immunosuppression is the mainstay of management of Mooren's ulcer. A stepwise approach, if the patient has if the patient has unilateral involvement up to one quadrant involvement, we can manage the patient with topical steroids. As it starts becoming more aggressive, oral steroids, oral immunomodulatory therapy can be considered. And in one-eyed patients, you will manage them with IV MP and IV cyclophosphamide. This is also considered in cases when there is an impending perforation. And surgical attempts have to be carried out only when there is concurrent adequate immunosuppression. Thank you, everyone, for your patient listening.
Thanks. Thanks, Dr. Anahita. That was a very elaborate, thorough talk. So, Shreyas.
Very nice talk, Anahita, and I think very exhaustive. Although we were looking at the stepladder management, you really went way beyond, and it was very, very lucid. Thank you so much for that. One question which I had, and I think it's a challenge which many ophthalmologists do face, because very often some of these patients tend to be from a socioeconomically weaker section of the society, do have challenges in following up with a higher center, far off center, and like you mentioned in so many of your cases, does require a long-term and regular follow-up. And the other very important thing is to achieve remission at the right stage, because if we are unable to control the disease at the right stage, we end up losing the eye altogether. So for a ophthalmologist who's practicing, even a cornea specialist, many of them are comfortable using oral steroids, maybe up to an IVMP, but start getting a little jittery when they have to start using a mycophenolate mofetil or a cyclophosphamide. And at times it becomes difficult to convince an immunologist or a rheumatologist nearby that for a very localized small ulcer, what they see in the eye or what they think is a red eye, that such kind of heavy immunosuppression is needed. So what would your general advice be, and how should they go about doing it? Should they be handling it entirely on their own, or should they be looking at other help as well, external help as well?
Should Anahita be answering? We could be asking our expert panels, no?
Sure. I thought we'll first hear from Anahita. She's an expert in immunology and therapy, and then of course we'll take it up with seniors.
Thank you, Dr. Shreyas. I think that is a situation that we very commonly face as ophthalmologists, where we want to start the patient on immunosuppression, the profile comes negative, and the rheumatologist does not want to start. So especially for patients who find it difficult to follow up, or in another common scenario that we encounter is that they do not have, they're not comfortable getting mycophenolate mofetil or azathioprine. MMF especially is expensive. So for these patients, and for somebody who's starting out immunosuppression on their own, methotrexate is an excellent drug. So this is a medication that is very easy for the patients to follow because it has a once weekly dose. What I tell my patients is to start the medication on a Sunday, and it is given with folate, so folate on Monday. And this is literally 4 tablets for the month. The compliance is very good. And for us as ophthalmologists to follow up the patients, it is a very simple regimen that we can follow. At baseline, get 3 tests, CBC, RFT, LFT, repeat the tests at 1 month. So for these things, if we will not involve a physician, if these tests, as long as the tests are normal, if there is some abnormality, we can take their help in understanding how to titrate the dose of the medication and understanding how to change from one medication to the other. But the onus of starting the medication, I think, especially for Mooren's, because the profile is usually negative, is on us as ophthalmologists. I would love to hear what the panel has to say on this.
Dr. Somshila had some other opinion to add. Yes, doctor, I saw you writing.
Yeah, hi, Dr. Chitra. Hi. Oh, sorry. I'll just fix the video. I think it's not working. So Anahita, first of all, great presentation. I think you just about covered everything possible and went beyond. So Anahita's initial presentation, I feel, is a stepladder pattern to PUK in general. So I would say that it's more of a PUK kind of a pattern that you had, where you would work up the patient systemically and so on. Whereas if I have a patient who has classical Mooren's, I will not do any ruling out collagen vascular disorders, and my only investigation would be for the fitness aspect, like the ones that you mentioned, viral screening, the blood sugars, and rule out tuberculosis and so on. So that definitely I would do. And in my experience, that I have seen that there's not been even a single patient where I've seen classical Mooren's and I said, ANCA is positive for this patient. So maybe it's GPA after all. So that's never happened. And I'm sure Shreyas and Anahita would agree as well. So this one conventional teaching we have in institutes, I think we should probably get out of it, that if the patient is a classical Mooren's, then you're not going to get anything. Whereas in the patient that you showed, Anahita, that lady who had inferior, it started from there. That didn't look classical till the later visits. So that patient, I think that it is prudent to do everything, all the workup. I would agree with that. The second difference of opinion I had from what Anahita has presented and published also, I think, is that despite the initial picture being mild, that is just that picture abhi baki hai kind of thing, and these patients worsen over time. And even if you get away with using topical steroids and fix the right eye with some conjunctival resection or whatever is required, they come back years later with the other eye involved. And the one-eyed patient you had would have started off like this. In the worst eye, would have had started off like this. So in my experience and practice, what I do is that I immunosuppress at least oral steroids, a course of oral steroids in the initial, when that particular patient you showed me, I would have started that off with the hope that she doesn't present with a worsened stage later. So that's what I had to add, Dr. Chitra.
Yeah, very valuable information.
You managed to follow the classical dictum where, the younger age patient, bilateral presentation, fewer versus more clock hours, all this which we were taught as a marker for a more aggressive initiation of therapy versus just topical steroid or just topical steroid with some oral steroid top-up.
Yeah.
In a very aggressive case of Mooren's, and like how well do these patch grafts do hold under immunosuppression? Sunita, Dr. Merle, anyone?
Yeah, I think some of the patients where they are not amenable, actually generally now the trend to do a corneal patch graft has sort of reduced because we have so many other ways of managing. The larger perforation you can actually manage with multi-layered AMG, with the T-nons patch graft. So these modalities are far more common now, which was probably not practiced earlier. But having said that, we have a few cases where we have to do a corneal patch graft. Once the disease is sufficiently controlled systemically, I think they do quite well. And there are patients where we have patch grafts in the long follow-up. They have been stable and doing well. So patch grafts, generally, the indications will be very few. But yes, if we have to, if the disease is under control, they do quite well. Dr. Somashila can also add, because I think earlier times, the main modality, because T-nons and AMG was not so popular that time, we used to do most of the times patch grafts only for these perforations in the periphery.
Yeah. Corneal patch grafts don't do well, neither does the large graft. So that would be the last option. Nothing else works.
Anything else to ask, Shreyas, before we go
on to the next topic?
If there is significant cataract and a severe melt, would you all do a triple procedure, or you leave the cataract and just do a penetrating arthroplasty? I suppose as a general ophthalmologist, we may get these kind of patients and there's a lot of cataract and our hands are always itching to do the cataract. What would be your advice be? Whom do I ask this question? Dr. Vanity?
Ask this question. Nobody will agree to do a triple procedure in this. But in this
Okay, then don't answer this question. Then fine. So then we go on to our next section. Just 1 minute. We have with us Dr. Vikas Mittal. A big hello to you, who's the founder of the LG Eye Institute from Ambala City and is a greatly innovative surgeon and brings out a lot of newer procedures and makes the cornea surgeons envy him. And he's going to be talking to us failed graft, DMEC versus DSEC, when and how. So on to you, Dr. Vikas.
Thank you so much, ma'am. And it's really a privilege, and it's lovely to see everyone here. And thank you so much for organizing this webinar. So from immunosuppression and all, we'll come to the hardcore surgical thing in cornea. So my topic is endothelial keratoplasty in a failed graft. So what happened? Okay, so why do we want to really talk about this? So I was just going through my archives, and this was the first EK in penetrating keratoplasty that was done by me. It was close to 12-13 years back. This patient had penetrating keratoplasty done by steel sutures, and she had come to me with this graft edema. I did a DSEC. This was my first DSEC in a failed graft, and I was really thrilled to see when it got cleared within 20 days. So as cornea surgeons, we do come across these failed grafts where the cornea is primarily edematous, and when we do an EK, we want to see our cornea to look something like this. Definitely, we don't want our cornea to look something like this where the graft is floating, the cornea is still edematous. So looks like that this topic is important. And so I'll just go through a few points that how best we can have our, the outcome which are, better. Of course, we are not dealing with these opaque grafts where you'll have to change it and we'll have to do penetrating keratoplasty. What I'm going to touch upon is grafts like this, where it is edematous, endothelium is not working, and that's why this edematous cornea is not reflecting the light well. We know that majority failure are endothelial failures, and this can be secondary to the multiple rejections. So once rejection is there, it can kill that endothelium. Or primary failure, surgical trauma. During the surgery, you have rubbed off this endothelium, or the endothelium got damaged. Or to start with, the graft who had a poor donor endothelium. Or there can be secondary failure, which is like progressive endothelial cell loss. Suppose after 10 years, 15 years, the cell slowly went down and ultimately the graft became edematous. So this is what has happened. So failed graft can be a failed PKP graft, or it can be a failed EK graft also. I'll cover both of them. Let's start with PKP. So I have divided this PKP part into pre-op, intra-op, and post-op, and what are the key factors that we have to look upon when we are dealing with these kind of patients. In pre-op planning, so if there is one investigation that is very important, these patients as anterior segment OCT. It's very, very important, which helps us to plan our cases well, because many times it's not only DSEC that you do or DMEC you do, you'll have to deal with some associated procedures as well. Then as far as prognosis is concerned, what was the indication for PKP? It was a high risk. If it was a high risk graft, then the survival will be poorer. If the patient had glaucoma or status for GFS, AGV, again, this will have some borderline prognosis. Of course, you'll have to do B scan to ensure that everything is right back there. So regarding this anterior segment OCT part, I'll just show you a few examples of what I'm talking about. Sometimes you, along with the DSEC, you'll have to do a cataract surgery or phacoemulsification. Sometimes you have this membrane, you can see it is membrane, the tight membrane over the iris. This patient had therapeutic PK. So maybe the initial inflammation, it has covered the whole iris. So you'll have to deal with this part also if you want to do an optical, make this graft optically behave well. And sometimes you have RCM or retrocorneal membrane. So when you are doing desmetorexis, you might have to remove first RCM and then do desmetorexis if you want. And many times, this is very important. The posterior graft-host junction, it is really ragged. So you need to take into account when you are planning your graft size or other things. So in pre-op, the main important part is the anterior segment OCT, so that you know that what you are going to deal with when you are going to do your endothelial keratoplasty, what else you're going to come across. Intra-op, suppose now the patient has taken to OR, what you are going to do. There are two things that comes in our mind, and we have to take decision on is whether you are going to strip DM or not in post, and what will be the diameter of graft. These are the two things which generally are important. Technique is like totally personal. You want to do a DSEC, TSEC, or sheet glide, boosting glide, DMEC, whatever. So that depends on whatever surgery you are comfortable with. It's important that we are going to talk about a bit about the incision and air retention also. So I'll show you a video and then we will discuss it more. So this patient had a therapeutic graft. You can see the large graft. So first I'm doing is removing that epithelium so that I have a better idea of, I can see that well. And now what I'm doing here is measuring the, just 1 minute, this I missed. So this is very important. So I'm measuring what is the graft size that I'm going to use. So I'm going to use smaller than this PKP graft. So I want my EK graft to be inside this old graft. Since it was a large graft, I have to make an incision within the graft. Although I would personally prefer if I can have these incisions in the host area. So now there was an RCM here, you can see. So that's why I'm doing this decimeter axis, and this decimeter axis will be within the graft host junction. You don't want to go near the graft host junction, so that because this PKP graft will be the best attached at the epithelium and at the endothelial level. So after removing that RCM, there was some descemet membrane that also had been removed. So now I generally make incision superior-nasal, and I generally use Busson glide for loading. I intentionally have made a thinner graft so that it drapes the posterior part of my PKP graft well. And then while using a crocodile forceps, it's pulled inside the AC. This is the superior temporal area, and AC maintainer is on, although the bottle height is down at this time. And once the graft goes inside, the ACM is removed, and ensure that these patients, you'll have to ensure that air stays that well, because this will be slightly on a higher risk for detachment. So we, in generally these cases, we ensure that the air remains there for 2 hours. And if there are this incisions which are leaky, ensure that I make sure that I suture all these incisions so that the air doesn't leak out. I want to ensure that the graft retains there for at least 2 hours. And after that, you can do air VSS exchange, and then this to the patient how we did very well. So in case, there are a few cases where you don't have to do decimeter access at all. And there you can do an NDSEC. NDSEC means you don't strip off the DM and straight away put the graft in. So what do we follow is that, suppose if you have KPs or iris pigments bang in the center, it's better to do a decimeter access. You have to ensure that at least 2 to 3 millimeter inside the GHA. If the endothelium is clean, means it is a progressive it's a failure due to progressive endothelial cell loss. There you can go ahead and do a NDSEC. This is a patient who had undergone a NDSEC, again a failed PKP. PK was done, I think, close to 8-9 years back. Same, first epithelium is removed to ensure that I can see everything well inside. And here, this is what I was talking about. I always prefer if I can have my incision in the host part. In the previous case, the graft was very big. So here, all the incision, the side ports, the port for AC maintainer, everything we are using in the host part of the cornea. Measuring how much diameter of graft I want to use. I want to use this diameter less than the diameter of PKP. Then entry also is just before the GA junction. So we don't want to touch the GA junction there, or try to avoid as much as possible. Then the same part, graft on the Busson glide and air, and ensure that the air stays well for good 2 hours. And in case you that's it. Okay, this was the same. So so DM stripping or non-DM stripping is pretty clear. So if your endothelium doesn't have its clean, you can go ahead and do a NDSEC. Diameter is very important. So there are studies where they feel that that the graft should be smaller than the PKP graft. But price group, they are very fond of putting a larger grafts, and they feel that if you put a larger graft, the more number of endothelial cells that goes inside. So there is no consensus. So what I feel is basically the posterior GHJ that is important. So sometimes you have a smooth posterior GHJ. There's a cakewalk. You can do DSEC, DMEC, whatever you want to do, or whatever size you want to choose. But sometimes you have this kind of GHJ, specifically posterior part. If you have so much ragged kind of thing, you have to be careful with your diameters. In these kind of eyes, it's better to use graft which is inside your graft host junction. So suppose you have a thicker graft and it is larger than the graft size, the PKP size. What will happen is there will be some area, potential area, from where the aqueous can go inside and cause the graft attachment. And it's possible that the next day you'll see something like this. So it's better that if you can have an access to NDA segment OCT, do it. And if it's a ragged posterior GHJ, better to use graft inside. And if you don't have OCT, I personally would suggest that have a diameter which is smaller than the graft host junction. Or in case you want to have Larger grafts
Sir,
ensure that
1
you can
minute more.
ultra thin graft. Yeah, sure. And similarly, you can do a DMAC also. That depends, how much you are comfortable with it. What we do is, if you have a clear case, you don't have to do any associated procedures. Then we do DMAC. But if you have to remove some, RCMs, or there is a possibility of some fibrin, then we prefer to do a DSEC. Post-ops are same. These are slightly high risk. So specifically, if there is vitrectomy associated. So these are the parameters of pre-op, intra-op, and post-op. And I'll just touch upon what do you do for the repeat DSEC. So what happens in repeat DSEC, what is important is descemeter excess. So what happens is the endothelium, it crawls and it secretes its own DM. So you get an adhesion somewhere here. So it's important to do a descemeter excess just beyond this the graft. Otherwise, if you can pull it, you might pull the whole base of the iris. So this is what I want to tell, that, so you do a descemeter excess all over, ensure that all adhesions are cut before you try to pull this DSEC graft. That is very important. And once those adhesions are cut, then it's absolutely, cakewalk, and you remove your old graft and put a new one with whatever technique you are, comfortable with. And the agent repeat DSEC, they do very well. And you can do a repeat if you have a DSEC and it's a clean case. This was a failed DSEC, although it was everything clean. So we went ahead, cutting off all the adhesions all over, then removing the DSEC graft. And this is the incision. And here we had done a routine DMAC. So if you just have to ensure that all the DM tags are removed, or when you want to do a DMAC in these kind of cases. And this is just a simple routine DMAC. And this was how the patient looked like. My last video is, this patient had failed PKP, then failed DSEC as well. So I just want to tell you that, sometimes removal of this DSEC graft becomes very tricky. So you have to ensure that, adhesions are cut. It's still, it's still there, but you must not pull them unless these adhesions are cut. So there were PS also. I am trying to use a reverse Sinski, trying to pull, very gently. But so I'm going inside. I went into the interface, and from that interface, I cut all those adhesions. And still in this area, it's still stuck. So there you can use your, crocodile or reverse MST to pull it. Here also, you need to be very gentle and ensure that you don't pull that base of the iris. And once this graft is out, rest is routine. So before I close, so I found some study where they found that if you do a repeat PKP for a failed PKP, this do better than, EK. And there are studies where they found that EK is better than PKP. And then there are studies where they found there's no significant difference. And this meta-analysis showed that, because there's heterogeneity of these cases, so we are not very sure. Although those of you who are doing PKP for failed PKP graft is definitely not a crime. So thank you so much.
Thanks a lot, Dr. Vikas. That was so interesting for me too. So I can imagine how it would be for all the audience watching from there. So Shreyas, on to you.
Thank you so much, Dr. Vikas. I mean, amazing set of videos as always, and so interesting to hear you. One thing, being a proficient DSEC as well as DMEC surgeon, because failed graft, like you already showed in your example, is such a heterogeneous variety, unlike the PBKs or the Fuchs, which are much more predictable. What is your preference of choice? What makes you choose a DSEC versus a DMEC? Apart from, of course, you did mention highlighted altered posterior corneal curvature, graft-closed junction. But apart from that, what are the other criteria which helps you choose when you're examining the patient on a slit?
So what I generally see is, if in this patient while surgery there are chances of increased fibrin, or suppose there's a RCM, there is PAS, and I'm going to break this PAS and it will bleed. Those kind of cases I do DSEC only. And I always very careful that I do an ultra thin DSEC in these cases. So for failed PKP graft, I think my DMEC would be somewhere around 10 to 20%. 80% of them are DSEC only. And it's simple, as you rightly said, that these are not like PBKs or Fuchs. most of the time there is some or the other thing also. Sometimes you have to put iris hooks. You have to do a phacoemulsification along with it. And sometimes the view is really bad. Though if your view is bad, you get a fibrin and you have, injected your DM inside, you'll have it. So for me, it's only the clean case, where that everything is fine. So those kind of cases, we can definitely do DMEC. Otherwise, majority of them we do DSEC.
Wonderful, sir. I mean, I think very nicely summarized. And any point you'd like to add, Sunita madam or Dr. Rajesh Sinha? Yes, madam.
Yeah, I think Vikas covered all aspects of nuances of choice between the two procedures very well, very comprehensively. One more thing which I would just want to add, which I feel is also relevant in this context, is to look at the age of the prior PK donor. Like, let's say if the prior PK donor was less than 40 years. So if you have to have a choice between DSEC versus DMEC, as such, the failed PK situation is a higher risk for detachments. As Vikas pointed out, like important and relevant, because the membrane has a very high risk of detachment if you traverse the graft-host junction. So those cases where let's say you use the cornea for the first prior PK, which is less than let's say 40 years. So we understand how difficult it is to strip these Descemet's membrane. So quite often, if you have to strip the Descemet's membrane, which is sort of a requirement, not like an absolute, but it's a requirement for DMEC, you end up causing tags in the posterior membrane. And these could additionally increase the risk of detachment. So those would be the other important thing in the preoperative assessment. Like if you have the details of the prior donor, will be good to add.
True. Agree.
Dr. Merle had something to add. Yes, Dr. Merle, can you tell us?
Yeah, so I was just mentioning about the need for suture removal. Sometimes you have significant amount of astigmatism that is pre-existing in these grafts. And it's important to have an understanding about that, because once you put in the DSEC lenticule and the cornea clears up, then you have a lot of astigmatism post-op, which doesn't give such a great visual outcome. So that may be something that we could look at by doing, say, a pentacam, particularly if the surface is not too irregular. That will give you an idea about where the sutures are tight, and maybe we could actually consider suture removal prior and then proceeding with the DSEC.
Yes.
True.
Another thing, I just wanted to add one thing, that if you have a large graft, then it's not a big issue, like a large failed graft, then it's not a big issue. The problem arises when you have an optical PK which has failed. This is 7.5 millimeter graft. There you have a problem when you have a graft-host junction, which is, the posterior lip is dipping posteriorly, as the OCT that Dr. Vikas had shown. So that is one issue. The other thing is that graft survival definitely will be better if we do EK. But sometimes if it's a long-standing failed graft, then the surface and the stromal clarity is not that great in some of the cases. Even if the graft is absolutely fine, the thickness is fine, but still there is some little bit of haze there. Sometimes you do feel that, maybe PK was a better choice in that. But if it's a large failed therapeutic graft, then obviously, as Dr. Merle was mentioning, we have to look at the astigmatism. But if it's not significantly there, then maybe EK is a better option in those. But something like a small grafts previously, it creates some issues.
But maybe a theoretical question: if it's a failed PK and then you have done a DMEC, and then would you, and a repeat failure, then would you do a repeat DMEC or would you do a DSEC only in those cases?
So that depends, if the case is clear, you can remove your old DM and put a new DM. It's absolutely no problem. So if you have done a DMEC, yes, Dr. Sinha, you want to say?
It depends on how much duration it was there and how much clarity of the cornea is there. Sometimes if it's a very long-standing failed graft and then the patient has come to you and it has become very much edematous and hazy, then maybe DSEC will be a better option. Otherwise, you can just remove the DMEC roll and put another roll.
True.
Thank you. So we go on to our next speaker, Dr. Yes, Shish.
So my indication for PK in failed PK is actually those who are having iris abnormalities, or if there is a large sector ilectomy, or if there is anti-segment abnormality, if there is a peripheral anterior synechia. In such cases, and as Merle mentioned, high astigmatism with the previous penetrating keratoplasty. These are the indications for penetrating keratoplasty in a failed PK. And if there is a significant vascularization, peripheral vascularization, or the surface is very bad, such cases I would prefer doing a endothelial graft. That is DSEK I prefer.
Thank you. We go on to our next speaker, Dr. Professor Rajesh Sinha, who is Professor of Cornea Lens and Refractive Services at RP Center, and is truly an amazing, versatile surgeon. As a cataract surgeon, I know he's just amazing, and I'm sure as a cornea, he would be heading too. So we are truly lucky to have him talking today on fungal keratitis, intrastromal and intracameral antifungal usage, timing, and frequency. On to you, Dr. Rajesh.
Thank you, Dr. Chitra, for the opportunity. I have a very specific topic, that is intrastromal and intracameral injections of antifungal agents in fungal keratitis. We all know that microbial keratitis is very common in India, nearly about 10 times out of the United States, and fungal pathogens are higher than the Western world. And most of our fungal keratitis, they do have a history of trauma with vegetative matter. There may not be. Essentially, this is what we see in many cases, but it may not be there. But the clinical picture is typically, dry, sometimes deep infiltrates, feathery margins, dry-looking ulcers, satellite lesions, endothelial plaques, and fixed hypopyon. And in order to treat all these, we have been using the topical antifungals like 5% natamycin, 1% voriconazole, 0.12% amphotericin B, particularly for Candida. And systemic antifungals are used because most of the times the topical antifungals don't have a very good penetration, and they don't go that deep. So systemic antifungals are required. Many times, because of the same reason, you do require repeated debridement of the ulcer. And in order to reach out to the area where the infiltrate is present, where the organism is multiplying, we have to give intracameral or intrastromal antifungal drugs. So it is like a targeted therapy. It is to place the antimicrobials in the area where it has to act, where there is active proliferation of microbes, and that is how we plan. So the indications can be fungal ulcers invading deep stromal infiltrates or deep endothelial plaque. Sometimes what happens that you have an ulcer which is it has a nice surface ulceration as well, and then going deep, and it is a proven fungal. You can manage with topical and repeated debridements, etc. But there are certain fungal keratitis wherein you don't have any epithelial breach, you have deep infiltrates. In such cases, because of the poor penetration of the antifungal drugs also, and because the superior surface is intact, the antifungals don't go very deep. So in such cases, intrastromal injections are very useful. Sometimes there are thick, cheesy, immobile hypopyons or endothelial plaques. There, if you require intracameral or even intrastromal. Then there's some fungal ulcers which don't respond to combination therapy of topical and oral antifungals. So there you have to use the targeted therapy of intrastromal and intracameral. Sometimes you do have interface infections wherein it doesn't work. Again, for the same reason, there's a place for the microbes to proliferate and the infiltrates to increase. So you have to give targeted therapy there. You have to use intrastromal injections. But in conditions wherein there is a lot of melting, there is thinning of cornea, in such cases it should be avoided. So that's why I said that as far as the rationale of giving intrastromal injections in fungal ulcer is concerned, the rationale is because these ulcers are difficult to treat. They involve deep stroma where penetration by topical agents is difficult. As such, all the antifungals have poor penetration, although voriconazole is slightly better than others, but still none of these drugs are very good as far as penetration is concerned. And that's why there's poor bioavailability of drugs. And many times because of this reason, you have a tendency to prolong your intensive topical medication, which further causes surface toxicity. And that is where one should think about giving the intrastromal or intracameral injections. The question is how many injections to be given. Like sometimes you give an injection and you feel disheartened that the response was not that great. But even if there is some response, there's fault of progression, then that is a response. And you have to give multiple injections, at least 3 injections in the vast majority, but 3 to 5 injections are required in many of the cases. A couple of reports have even reported more injections for these fungal keratitis. But what we have noted is anything around 3, 4, 5 injections, they do well. And as far as preparation of voriconazole is concerned, which is a very useful antifungal agent, which is more often given these days, it is available in 200 milligram vial. So you reconstitute the drug with 19 ml ringer lactate to get a 200 milligram in 20 ml, that is 10 milligram per ml. Then 1 ml of this solution is further diluted in 20 ml of ringer lactate, giving a 0.5 milligram per ml, that is 50 micrograms in 0.1 ml. And that is how you give the injection. As far as amphotericin B is concerned, the intrastromal dose is 5 microgram in 0.1 ml. So you mix 50 milligram powder of amphotericin B in 10 ml dextrose, 5% to give concentration of 5 milligram per ml, and 500 microgram in 0.1 ml, in other words. And then rather 5 milligram in 0.1 ml. That's a mistake. And then this concentration is diluted with 9.9 ml dextrose 5% in tuberculin syringe to give a concentration of 500 microgram in 10 ml and 50 mics. A lot of calculations. So 50 microgram per ml, which means 5 microgram in 0.1 ml. 1 ml has 50 micrograms, so 0.1 ml will have 5 micrograms. As far as the technique is concerned, the intrastromal injections can be given under topical or peribulbar anesthesia, whichever you prefer. It depends on the patient's behavior and the patient's, how much patient is cooperative. It depends on the age, depends on cooperation of the patient, understanding of the patient. Under full aseptic condition, the preloaded drug is administered in an operation theater under the operating microscope. You use 30 gauge needle. It is introduced beveled down. A needle is inserted obliquely from uninvolved area, and you reach the edge of the infiltrate, and then you inject. When you inject, you see the amount of hydration that it is causing. And then you again go to other side. And this is how you create a barrage of hydration all around the infiltrate, so as to cover all around with the intrastromal injection. And of course, as far as intracameral injection is concerned, you wash it thoroughly, wash the anterior chamber with hypopyon, and then you inject the intracameral drug. This is one case of a proven Sorry, the video is.
You can tell us what it was to show.
Actually, it's the video wherein intracameral injection, first the thorough wash was given, and then intracameral injection was given, and then intrastromal injections were given all around, creating a barrage. I'm really sorry why it's not running.
You may have to exit and play it from the source files.
Yeah.
Not copy.
Do we have time to do that? Or maybe we can just complete the slides and come back.
Yeah. Do that.
Okay. So this is after the first injection. This is day 1 post-op. And then in this particular patient, and this is day 5 post-op after the second injection. And then the patient required a third injection as well. We had earlier also published case reports and case series of intrastromal injections in fungal keratitis. This was published long back in 2005 when we had injected intrastromal amphotericin B. And with 2 injections, the infiltrates disappeared almost completely and it worked quite well. Then we had a case series of intrastromal voriconazole, wherein this is a case of a fungal keratitis, wherein intrastromal voriconazole was given and it improved significantly. Another case, which again with injections, another case with injections of intrastromal voriconazole, it improved significantly. The dose is 50 microgram in 0.1 ml. And these are some of the articles that have been published in this field. There was one article which one of these articles was from our center, and herein we compared intrastromal voriconazole versus amphotericin B versus natamycin as adjunct to topical natamycin in cases of recalcitrant fungal keratitis. And we included 60 eyes of 60 patients with proven.
Doctor, 1 minute more.
Okay, proven fungal keratitis, and wherein the ulcer size was more than 2 millimeters, depth was more than 50% of stroma, not responding to topical natamycin therapy for 2 weeks, they were recruited. And there were 3 groups, one receiving intrastromal voriconazole, one intrastromal amphotericin B, and the third intrastromal natamycin. And we found out that marginally the intrastromal natamycin was better than intrastromal voriconazole, just the healing response just by 2 days. And although that was not significant, but there was a significant difference from the amphotericin B. And another thing was deep vascularization was significantly greater in the groups of intrastromal amphotericin B. So in conclusion, the intrastromal and intracameral antifungal drugs are a way of giving direct drug delivery to the area of microbial proliferation. And it overcomes the problems of poor penetration of drug, and it acts as a depot. And of course, less epithelial toxicity, and it acts as an adjunct. You cannot say that it can alone work, but it acts as an useful adjunct along with the topical medication. So this is what I would like to say, that maybe when we feel that it's time, it's deep infiltrate, it's not responding, for 2 weeks of topical therapy, we can go ahead and give intrastromal and intracameral antifungals. And the only thing is that we have to understand that a large majority of patients, they require multiple injections. Not by a single injection, hardly any keratitis will resolve. You may require multiple injections. And it is especially useful when you have a deep infiltrate, no ulceration superficially, but you have deep infiltrate, typically like fungal keratitis, endothelial plaque, etc. Go deep, go intrastromally, inject, make a barrage, and it works very well. So thank you very much for your patient listening. And
thanks a lot, Rajesh. You actually covered nearly everything. I wonder what Shreyash is going to ask.
Sorry for the video. I don't know why.
Yeah.
In the evening it was running and suddenly.
Extremely nice talk, sir. And who better than someone from you, like you, to present on this data, because most of the papers on this topic, I think, has been written by you and your team. So really nice to hear it from you firsthand. One question which I have, because very often as cornea consultants, we are in this catch-22 situation where you want to give a good trial of medical therapy, but at the same time, you don't want the ulcer to worsen, that you end up with a very large therapeutic graft, possibly, compromising the limbus. So like you mentioned, we know that multiple injections are required. So when do you say, I will keep trying injections? When do you say that this patient it's probably not going to work and I have to do an early TPK? Are there any specific pointers that you look for?
Yeah, if it's worsening, then definitely you have to go for TPK. If it has responded, even if it has halted, there's no reduction in infiltrate, but still it has halted by the first injection, you may feel like giving the second injection to see if it's reducing. And if it has started reducing, then maybe after 72 hours further, you can give another injection. But if after the first injection, it has worsened, the second thing is that sometimes what we have felt is that even the needle track gets infected. And if that is also happening, then it is time that you have to intervene fast and go ahead and do a TPK.
The second quick question before we ask our expert panel as well, sir, is that like you mentioned in deep-seated focal ulcers, we find this extremely useful. But I saw you show some pictures of fairly large widespread ulcers also where you have tried this. Do you find it to be of consistent help even in these widespread ulcers? Intrastromal?
Yes, it does. Even in widespread ulcers, it does. And what happens that sometimes when you're giving topical medication and it's not working, then it's worth trying these intrastromal and intracameral. And particularly when you're giving both, what you do is that you can remove some of the endothelial plaques as well. Sometimes these fibrinous, plaques, they are attached to the endothelium. You can separate it and then wash it thoroughly, give intracameral, give intrastromal. And in many patients, it works. If it's not working, as I said, if it's worsening, the needle tract getting infected, nothing is working, go ahead and do a TPK. But it is worth trying before you are, thinking about TPK.
Yeah.
Any thoughts, Radhika madam or Revati madam? Will also.
Yes.
Yeah, Shreyas, like you said, it was nice hearing firsthand from the flagship institute that is a proponent of many of these techniques. I only have one point to add that while giving the intrastromal, I choose to give, like you said, deep-seated focal cases, because I've not had much benefit in giving for the widespread ones. It's more dicey to give that because you need to give it in the kind of normal area or the interface between the normal area and the ulcer, which is very less in these cases. Also, I like to give it when it is microbiologically proven fungus. We, in one very rare case, burnt our fingers. It looked like a deep infiltrate of fungus, but it turned out to be atypical mycobacteria, which we realized after wasting a little bit of time. And for that purpose, sometimes if you're not able to get the microbiological sample, I do what is called as a trapdoor biopsy. I open a small trabeculectomy-like flap on the cornea so that you can reach the infection better. And even if you have a perforation, you have that flap to put it right back. And there you scrape out and take the sample. Also, the access of the intrastromal injection is a little better when we do it. Last but not the least, their group has also published this particular effect that in the end, it's a small consequence to bear, but it also invites a lot of vascularization at the time of healing when you give these injections, opens up some channels. So we have to be mentally prepared for tackling those at the time of the optical graft. These are my few takes on the matter.
True, very true.
I think
that's was seen more with recently, but also with voriconazole. Yes.
Okay. Is there any role at all of oral antifungal for any severe infection?
Very much.
Anybody on the expert panel?
Very much.
Very much.
Yeah.
Yeah. Is it when it's a scleral involvement or if it's corneal itself?
It's a corneal involvement there also. Systemic antifungals do have a role. Yes, as Dr. Radhika was mentioning, we have to be careful that it should be a proven fungal keratitis. Then only you should give all these systemic antifungals, etc. But yes, if it's a proven fungal keratitis, systemic antifungals do have a definite role.
I would like to differ here. We did a randomized trial also with ketoconazole because those trials only that was the oral drug available. And we didn't find any additional advantage by using ketoconazole. Voriconazole, of course, in MAT2 trial, they have tried, but then also they have showed that the incidence of TPK is not reduced or anything by using voriconazole. But of course, it was done in little severe ulcers, not the initial ones. But they said by using that, even in fusarium, there is a little bit advantage of late reinfection and other things are less. That was the only thing. But we have to consider all these oral antifungals are quite toxic and we have to be very careful, even including voriconazole and the economic part of it also when considering this. But comparatively, regional infiltrate of the medication, I think that is more logical and rational than giving systemic.
Yeah, that's true. It's safer. And obviously, when you're giving systemic medication, you have to look for all these liver function tests, renal function tests. Everything has to be done.
Thank you. Thank you, Dr. Rajesh. We want to
Rajesh, one question to you. So this intrastromal dosage of Keratoconus only is 50 micrograms per 0.1 ml, but intracameral dosage is higher, actually 100 micrograms. So why is actually you need a higher concentration for intrastomal injection than an intracameral injection?
Well, difficult to say that.
Okay.
I think, while we do reconstitute, sir, I'm not sure how many of us are exactly measuring the amount which goes intrastomally. We are more keen on giving a barrage and surrounding the ulcer than actually measuring the quantity which has gone into the stroma, unlike we do, like what we do in intracameral usually.
True. That's true.
So thank you very much, Dr. Rajesh. We go on to our next speaker, Dr. Paras Mehta, who heads the Sameep Eye Hospital and Cornea Center, Vadodara, and she's going to be talking on another very interesting topic, OSSN and primary topical chemotherapy versus surgery, followed by topical chemotherapy. On to you, Dr. Paras.
Good evening, one and all. And thank you, ma'am, for having me here. It is a privilege and honor to be part of this forum amongst all these stalwarts. I would just share my screen. The topic is ocular surface squamous neoplasia, primary topical chemotherapy versus surgery followed by topical chemotherapy. Actually speaking, this almost goes kind of, complementary to each other. As we progress through the presentation, we'll know about it. Nil financial disclosures. The treatment of ocular surface squamous neoplasia has changed significantly in past 2 decades due to greater understanding of the disease, improved diagnostic approaches, and a shift towards the medical management of these tumors. If we look at ocular surface squamous neoplasia is an encompassing term for precancerous as well as cancerous epithelial lesions of the conjunctiva and cornea, which includes the spectrum of dysplasia, carcinoma in situ, that is known as CIN, and invasive tumor, that is OSSN. There are no consistent clinical criteria for distinguishing CIN from invasive surface neoplasia, but diagnostic imaging is an important tool in diagnosis and management of these cases. Surface neoplasia normally occurs in the interpalpebral region arising from the limbal stem cells. And morphologically, it could be, as you can see here in the clinical pictures, it could be a placoid lesion, it could be having keratin, it could be small, it could have it could be flat, also involving the corneal surface, which is known as pagetoid spread on the cornea. It could be having a papilliform lesion, as you can see here, or very large nodular or flat lesions. So variety of, presentations could be there. It may be associated with very thick feeder vessels, and there may be presence of leukoplakia. So presence of leukoplakia, a placoid lesion, and presence of feeder vessels would almost clinch the diagnosis clinically. We know that there are various risk factors, and important amongst them are infection with HIV, human papilloma virus, and xeroderma pigmentosa. Rest is very well known to all of us, and this is a clinical picture showing a girl having xeroderma pigmentosa and a surface neoplasia in her one eye. The diagnosis is most often made clinically, but one can use confocal microscopy and ultra-high resolution optical coherence tomography, which is a very valuable addition to the diagnosis of OSSN. I'm sorry I couldn't include the pictures of anti-segment OCT here. Although there is no agreed consensus regarding the management of surface neoplasia, the management ranges from topical immunomodulation therapy to a radical surgery like exentration, depending on the presentation of the surface neoplasia. So the treatment options here for these kind of tumors would be medical in the form of topical and or intralesional interferon alpha 2b, mitomycin C, 5-fluorouracil, or it could be surgical, which could be simple excision, or along with adjuvant therapies like cryotherapy, and a combination of medical and surgical treatment options. Before we move on to these treatment options, we'll go through some of the clinical cases. Here is a 60-year-old female who presented to us with whitish lesion on the eye, redness, pain, and watering for past 3 weeks. And as you can see here, that this elevated lesion with grayish pannus-like appearance onto the cornea with few vessels, and this elevated lesion clinches the diagnosis of surface neoplasia. The ocular surface tumors are better delineated on red-free filter with a rose Bengal staining on slit lamp examination, as you can see here very well. So presence of keratin, heavy feeder vessels, and placoid lesion at the limbus, they are the hallmarks of surface neoplasia, and that is how the diagnosis was clinically made. This patient was treated on 2 cycles of topical 0.04% mitomycin C eye drops because this is easily available to us and it is cheaper. The lesion almost resolved just on medical management. As you can see here, you don't see that lesion at all. So this is how it responded. This is one case. The other case is a 58-year-old female who presented with redness watering since 4 months. Initially, she was treated on the line of epicellaritis elsewhere, but she had all classical features like presence of keratin on the surface, as you can see here, a placoid lesion, and very, thick feeder vessels. But if you look at the lesion was extending quite far beyond. It was extending from 11 o'clock to 5 o'clock, as you can see here in the collage of the in this picture. With, temporal bulbar conjunctival involvement and a grayish flat lesion sitting onto the cornea as well. It is seen much better on a red-free filter, as you can appreciate it very well. So she underwent 5 cycles of topical mitomycin C because she was responding. So we went on continuing the cycles. The lesion disappeared. But unfortunately, after discontinuation of the topical chemotherapy, the lesion appeared almost this much. So she underwent, we had to take another call, and later she underwent surgical excision with cryo application to the free conjunctival margins, and the area was covered with an amniotic membrane. A third case, which is a 70-year-old female coming from a small village, presented with, redness and occasional pain for last 2.5 months, coming from a farmer family. And this is how it looked. You can see a very nice lesion onto the cornea. This is seen very well on a dilated pupil. Sorry for that. And the corneal lesion can see very well on a dilated pupil and with a rose Bengal stain and red-free filter. So she had a pagetoid lesion onto the cornea as well. We started with chemo reduction, but she did not show much of improvement onto that. And she was followed by excision biopsy with cryo with a free conjunctival margin, freeze-thaw freeze technique with an AMG onto the resected area. And this is how the histopathological pictures appeared. She had infiltrative squamous neoplasia with keratin onto the surface. Prior to the development of high-resolution imaging modalities of the ocular surface, histopathological examination of biopsy specimens was the only way to diagnose these and to grade the surface neoplasia. So the traditional treatment of surface neoplasia has been surgical excision with wide margins and intraoperative cryotherapy. Although the popularity of topical therapies for OSSN has grown rapidly in recent years, surgical excision still remains most important treatment options in the management of surface neoplasia, especially in elderly patients where hand-eye coordination is poor, or at times the cost is a factor for long-term therapy, or when frequent follow-ups are needed and it is difficult for the relatives to bring the patient to the clinics. The advantages of this technique include complete histopathological assessment of the surgical excision margins and lower recurrence rate compared with simple excision. The goal of adding adjuvant therapy is to kill any residual tumor cells which are there in the peripheral margins. If you look at if we do a complete removal, the recurrence of tumors with negative margins is reported to be 0 to 33%, which can jump to almost 50% in cases of incomplete tumor removal. We'll just have a small, short video of surgical excision of surface neoplasia. This patient was treated with chemotherapy prior to the surgical excision. The surgery is done with a known touch technique. The corneal epithelium is removed with alcohol epitheliectomy. And as you can see, we just lift the tumor from the base of the tumor base, and then it is subjected for histopathological examination. And this area is covered with amniotic membrane. At times, people do use conjunctival graft also to cover that area to prevent limbus stem cell deficiency in those cases. Despite the surgeon's best efforts for complete surgical excision, this does not always occur, and which happens because of sometimes subclinical or microscopic disease. So different treatment options have been used for management of positive surgical margins, which includes either a surgical re-excision of the positive margins or one can use chemotherapeutic agents, that is MMC or interferon alpha 2B, without further surgical excision. However, the usual problem with this approach is that often there is no visible tumor, and therefore the surgeon must essentially use larger margins in the hope of clearing the tumor. If the original specimen is well oriented meticulously, then only the surgeon can focus on those areas of excision of the margins, like because the pathologist would report that which area is positive, which margin is positive. Interestingly, Gaylor et al. Showed that treating patients with positive margins post-operatively with interferon alpha 2B for a mean period of at least 2 months decreased the recurrence rates to that seen with negative margins. So this is a very important point, and maybe probably post-surgery, we can treat these patients with interferon for 2 months. The protocol of positive margins includes repeated surgical resection or topical interferon, that is 1 million international units per ml 4 times a day for 2 months due to its low side effect profile. And the authors also suggest the use of topical interferon in patients with increased risk of recurrence, even in cases of negative margins on histopathology owing to its high patient tolerance.
Doctor, 1 minute more.
Yeah, I'll just, summarize in a couple of slides only. So the medical management would consist of interferon alpha 2B, MMC, and 5-fluorouracil. We have a table here which talks about all the 3 components. In our country, MMC is easily available. In Western country, Western world, MMC is not easily available. So generally, they prefer to use interferon. Generally, they prefer to use interferon or 5-FU. 5-FU is used 1 person 4 times a day for 1 week and 3 weeks rest, while MMC is used in 0.02% or 0.04% drops 4 times a day. It could be 2 weeks on, 2 weeks off cycle, or it could be 1 week on, 1 week off cycle, or some people prefer to use 4 days in a week and rest of the days it is off. Both these, MMC and interferon needs refrigeration, while the 5-FU does not need any refrigeration. There are other therapies like photodynamic therapies or plaque brachytherapy also has been recommended. The factors such as tarsal involvement, positive pathological margins, and a higher pathological tumor grade have all been implicated in disease recurrence. Such cases may need tailored approach. We'll just skip this slide and summarize a careful management, planning, and optimal use of treatment options, including multimodal treatment, that is medical management as well as surgical management, can result in minimal recurrence and complications. A compliance to therapy and follow-up are the key to remission of the disease. If availability and compliance is not the issue, it is best to use topical interferon as medical therapy first, followed by other options. So the future holds increased medical management for surface neoplasia, and many physicians may find it to be the best option for the patient, especially in recurrent or very, very extensive disease. Thank you for your kind attention.
Thank you, Dr. Paris. That was a wonderful talk. And
thank you, ma'am.
Greatly covered everything.
Very nice talk, madam, and real pleasure having you here with us as part of this forum, and really enjoyed listening to you.
Thank you.
With the advent of interferon, like you mentioned, madam, it has really made things given us a lot more options in terms of primary immunotherapy or just a primary chemo reduction or post-surgery prophylactic treatment to prevent recurrence, especially if the margins are positive. So with the options available now, madam, do you have any size of OSSN where you directly go for surgical therapy, or every patient you are trying primary immunotherapy first, or HIV or other subset of individuals where you would probably prefer surgical versus topical?
Actually, earlier it was believed that, smaller lesions would respond very well to immunomodulatory therapy or chemo reduction. But of late, most of the surgeons prefer even in very extensive disease to reduce as you saw it in second case, which I presented, to reduce the tumor size so that the amount which we need to excise would be much smaller, and probably we would be avoiding complications like limbal stem cell deficiency and all. People use it even in a tarsal involvement, though this area is not in our domain. It is in the area of oculoplasty surgeons. but they do use it immunomodulatory therapy for tarsal involvement. And later it is followed by probably plaque brachytherapy or other modalities of treatment, or maybe exenteration if it is very worse or there is a recurrence in the disease process.
Thoughts on topical versus perilesional injectable interferon? Where do you use them?
In fact, as a cornea surgeon, I have not used it. Perilesional one can use in a higher dose also, 3 million international units. But again, probably, there would be a risk of sealing of the cells. And maybe probably for a very large lesions, that would be useful. So personally, I don't have any experience of using perilesional because topical works very well in all these cases.
Thoughts of the expert panel on using perilesional?
Dr. Bhaskar has joined us. So, sir, your views?
The problem with interferon right now is it's the availability. It's not freely available. So that's a major issue. So we have now stuck primarily with mitomycin and 5-FU. Between both, if at all you want to use, then probably a 5-FU subconjunctivally, but you don't have too much of literature on that. So it is preferable to use it as drops. And like Paras said, the idea would be if it's a very large lesion, yes, try to reduce it so that you can, you have to excise less amount of conjunctiva when you plan for surgical excision. And if the lesion responds well and you don't have any side effects, then you might avoid surgery. For a smaller lesion, especially if it's like a flat lesion and if it's primarily on the cornea, that tends to respond very well to topical chemotherapy as such. If it's a nodular lesion that you are seeing, you can feel the hardness, you can feel that the sclera is involved. That means it's already a invasive squamous cell carcinoma. That is not going to respond to topical chemotherapy. You have to plan for surgical. And if your sclera is involved, you might have to either do a partial sclerectomy or you might have to consider plaque brachy if you once you have excised it and your base is not clear.
Dr. Sunita, Dr. Vanity, wanted your thoughts, like if it's a large excision, would you think of combining slit at the same time or would you do a secondary slit? Dr. Sunita, Dr. Vanity, Dr. Merle. I want my expert panel to be awake.
Yeah, we don't manage, we don't have to manage, fortunately, OSSN. We refer to our oncology team. But yes, I'm aware of the treatment protocol. Some patients where you have an extensive lesion at the limbus, so our oncology team does do primary excision along with slit at the same time. So there is a paper also on that. And there are a few things which you have to monitor in the post-operative period because, it may sound really little controversial to plan slit at the same time. But I think it is done for a small subset of eyes after pre-operative investigations, and which cases will benefit from that. It is done in the same stage as well.
If I could just add, the LVP group does have published the report with the autoslit for large excisions, and we have published our result of alloslit in large excisions in a series of 3 patients. There are pros and cons of both. The worry with an autoslit is one, you don't want, if you're going to be touching both the eyes, you have to absolutely make sure that there is no cross contamination of the instruments when you are taking a tissue bit from the other eye. 2, when you are excising a lesion, you still do not know what the basic histopathology of that tumor is. It's going to be. If it is something which is going to be a more aggressive variant, and you're going to be putting an autogenic tissue there, you might want to consider a brachytherapy later, or you might want to consider something else. You're already priming the autogenic because you're already taking a bit of tissue from the normal eye. So in our series of 3 patients where there was extensive tumor, where we knew there's no limbus which is going to be left behind, but we wanted the surface to epithelize faster so that the risk of symblepharon formation, surface breakdown becomes lesser. And out of the 3, 1 patient was, if I'm not mistaken, that was the only eye of that patient. We did a allogenic slit. Excise. So at least even if we have to use a topical, say at that point of time, topical interferon as a prophylaxis post-surgery, the cells that we are transplanting, we know it will last. If it fails, I have the option of going to the right eye or the other eye and harvesting the limbal tissue. What we did see was the symblepharon severity was much lesser in these eyes. Otherwise, when you excise a large lesion and you put amniotic, invariably you will end up getting a significant symblepharon. Those things were not there because the surface epithelized faster. And that happens even if you do an autoslit or an alloslit. but we felt a little bit concerned about using an autologous slit in those cases. So we went ahead and used an allogenic slit.
Dr. Vanity, you have something to add?
I think intralesional steroids, they do work well, especially if patients cannot come over for over a long period of time and come back to us if they want. You need to give for a period of about 6 to 8 weeks here. And again, topical interferons work best when you're giving for CIN lesions here. They just melt away very fast, and then you don't need a long follow-up. But you do need to see your patients intermittently, and early staining with rose bengal is what is going to pick up these patients of recurrences here. So if you're slightly larger, moderate sized tumors, and intralesional has worked well, and we have about 82% success in the case series which we have published with us. And of course, we do refer larger patients for our plaque therapy, and we have Dr. Lomi in our unit who takes care of the plaque therapy for these patients. And as Bhaskar rightly pointed out, I think managing stem cell therapy concerns largely is going to be how the patient is behaving here. And you have a large tumor, a large amount of the surface already compromised. You're probably looking at removing and making the surface tumor-free first before you're going to think about other methods of surface rehabilitation and vision rehabilitation for the patient.
Thank you. We go on to our next speaker, Shreyas. Yeah, you are muted, I think. Our next speaker is none other than Dr. Radhika Natarajan, who's the Deputy Director of the Department of Cornea and Refractive Surgery and heads the Department of Teaching and Training in Shankar Nethralaya, Chennai. And she is going to talk on something so relevant to us in our day-to-day practice, recurrent SPKs, differential diagnosis and management options. Thanks a lot, Dr. Radhika, for being with us today. So on to you.
Thanks a lot for having me here, Dr. Chitra, in this galaxy of cornea people. Can you hear me?
Yes.
And see my slides as well? So we know the thought hypothesis that, the cornea replenishes itself on the ocular surface, that the cells are denuded and the cells are, migrating, the two should match. But it's actually more complex than that. If you look at that little box, when the cells are getting shed and repopulated, the new cells, epithelial cells, should be healthy. They should stratify themselves properly, and then they form the surface before being shed again. So if the shedding is not equal to the repopulation, then we get a corneal epithelial defect. If the repopulation is good, but the attachment is not good and the cells erode themselves, then we have corneal erosion. And sometimes the cells which are repopulating are not very healthy, and the environment is not good, the stratification is not good, and then we get superficial punctate keratopathy, which is the topic of my talk today. So treating superficial punctate keratopathy entirely depends on the way it presents in the clinic, its severity and the appearance. Conservatively, we could use lubricants. I'm not for using antibiotics. Some people patch the eye, people use therapeutic contact lenses. And surgically, sometimes you may need to remove unhealthy epithelium. You may need to use amniotic membrane as a biological contact lens. You may need to do a chemical tarsorrhaphy with Botox or a surgical one. And if limbus is deficient, you may need to put the limbus back. But what is most important is, if possible, to find and control the etiology. Then you have a holistic approach and you have a chance of preventing this from happening again, because SPK, like fever or lymphadenopathy, is just a sign. It belies a deficiency of health of the underlying ocular surface, which needs to be corrected first. The most common SPK that we see is associated with adenoviral keratoconjunctivitis. You see those dot-like SPKs, but what interests me far more is the second stage. The second picture shows you fine granular infiltrate below these SPKs, and this is a blink or miss stage. It's a fleeting stage. It's important to catch this because if at all you want to give steroid, it is in this stage. If it moves on to that third stage of scarring, you may treat all that you want with steroid. You'll end up only with side effect of steroid, but you will not have any effect at all. This is a patient with microsporidial keratoconjunctivitis, very common in the rainy season. These SPKs have a characteristic stuck-on appearance, which you see over there. They debride very well. They debride very easily, and quite often that is the only treatment that is required. Even though people use fluconazole and other medication, on debridement, this particular patient showed the characteristic, small rice grain-like appearance on the staining. And after that treatment, you can see that the cornea is looking better in the next picture. So this is a youngster who came with bilateral crater-like SPKs. It's the third variant. And this boy had traveled to Canada. And because of that suspicion, we did a serology. His antibodies came IgG positive for EBV, Epstein-Barr virus. And however, IgM positivity is required to ascertain active EBV disease itself, which requires antiviral treatment. Since only IgG was positive, it's probably a remote exposure in Canada. And this set of crater-like SPKs were treated conservatively for him. HSV keratitis also starts with superficial punctate keratopathy. You can see in the first picture, fat virus-laden epithelial cells over there. These accumulate or aggregate to form the classic dendrite, which you can see in the two pictures on top. And those dendrites coalesce to form the geographic ulcer, which you can see below. And later, when the disease itself has burned out, then you get epithelial roughening, which is quite different from the starting SPKs. And in this neurotrophic cornea, you can see those areas of epithelial roughening around an epithelial defect, which is struggling to heal. Moving on to corneal dystrophies, this is a case of bilateral epithelial basement membrane dystrophy. You can see the typical flower dusting of the subepithelial cornea. Here, the attachment of the epithelium to the basement membrane is very weak. This picture is a little subtle, but this ASOCT shows it quite clearly. You have those deficits over which the epithelium is sitting uncomfortably, and therefore you tend to get recurrent corneal erosions like these. That is why the logic of debriding the epithelium and treating it with a PTK, say, for example, to smoothen the cornea so that the epithelium can then sit better on the surface. So when you see bilateral, diffuse, dull, symmetric fluorescein staining like this, quite often there is a problem with the tear or the blink or both. This is a patient with aqueous deficiency dry eye, but you can see a similar pattern also in patients with a reduced blink rate, both quality and quality of blinking, like in Parkinson's disease. Here is a patient who was treated for infectious keratitis. You see the first picture, the infiltrate is resolving, but the area of interest is the remainder of the cornea, which is looking dull and lusterless on its surface because of the toxicity of the medication. Once the disease resolved, the antibiotics were stopped and lubricants were instated. And then you can see in the next picture, the epithelium has rejuvenated to its glossy self. In medicamentosa, you see corneal spotting like this with fluorescein, but where you have to look more carefully is at the inferior conjunctiva. The second picture shows nice conjunctival staining, which may be your clue to the toxicity. Here is a patient with facial palsy causing lag of thalamus. The blink is not good. You can see that the eye is not closing properly. And in tandem, the Bell's phenomenon, which lifts the globe as a protective mechanism, is also altered. You can see both in the first picture, and consequently, you can see snaking epitheliopathy in the inferior half of the cornea in the second picture. So here is a patient who was referred to us, a young patient with bilateral, large, elevated SPKs. He was diagnosed to have Thigh-Gissens keratitis. And these patients, very difficult to treat them without steroids. They're a pathetic lot who struggle a lot when you wean them on steroids. These large SPKs come back again. Thigh-Gissens is a diagnosis of exclusion. But there is one pointer which may help you. In these large SPKs, when you stain them, you can sometimes see negative staining, which you can see in this zoomed up picture. A lot of fluorescein around the large SPKs rather than actually into them. So moving on from global to focal SPKs, the first picture shows you cluster of SPKs just in the superior cornea, which obviously means there's something wrong just over there. And lo and behold, the second picture shows you a protruding suture node. So basically, the epithelium cannot jump over and heal itself, and that is what causing the disturbance in the superior part. Also similar case where you have cobblestone papillae in a VKC patient where the lid touches the cornea, you can see SPKs or Tog-B's keratitis. And if left unchecked, you see below that it can also progress to the vicious shield ulceration. Sometimes you may not have a limbal deficiency, you may not have a healthy limbus, you may have what is called as limbal stress. This happens when the patient is on long-term medication, has been treated for infection for a long time, or sometimes has had multiple surgeries. Then you see this whirling pattern of epitheliopathy. Whirling is nothing but the normal migrating direction, centripetal migration of the epithelial cells. But here the cells are unhealthy, they move slowly. So you can see the fluorescent picture showing the whirl very nicely. It's a classic picture. Should be differentiated from cornea verticillata, where the limbus and the cornea are normal, but it's actually deposits of drug or storage material on the cornea, into the corneal epithelium. Aniridia is a congenital condition which has got deficient limbus, and these patients always have a sandpaper like a rough ocular surface. And because they've had this from childhood all their life, you can see in this patient, it has also caused a little bit of corneal thinning and scarring. This can also be seen in one other condition, which is xeroderma pigmentosa, which also has deficient limbus. Here it is congenital, there it is because of photic damage, but the clinical presentation looks largely similar. So this is a boy, school boy, who came with bilateral coarse SPKs. These are the coarsest SPKs I have ever seen. There were the lids were normal. You can see in the inset over there, and there was no autoimmune disease on blood test. And because it was bilateral and inferior, after a laborious analysis, we found out that he was actually instilling hand gel into his eye, sanitizer into his lower fornix to escape online classes. So even though we diagnosed this, after a multitude of tests and treatment, factitious disorder should be remembered to be a diagnosis of exclusion only. I put up this slide for its, very different kind of presentation. Sometimes when you look at the diffuse illumination on slit lamp, it may be difficult to miss subtle or focal SPKs. You can't even see them in this picture. A good idea, if you suspect them, would be to throw the light on the iris, and that indirect illumination may help you pick up the SPKs, as you can see in this very same patient. This is my last and final favorite slide, where this is a 10-year-old child who was constantly being treated for episcleritis elsewhere. Now, that itself is a red flag. Still, children don't get episcleritis that commonly. And he was treated on a multitude of steroid and antibiotic medications as usual. When he came to us, he gave a vague history of fingernail injury. And the arrowhead points to the area where there was conjunctival edema around the area of the fingernail injury, which was mistaken to be episcleritis. And when we stained him with fluorescein, we got the diagnosis. You can see the abrasion on the conjunctiva, both in the color picture as well as in the fluorescein picture. So what was happening after the conjunctival abrasion was all the steroids and antibiotics were not allowing that area to heal. And it gave the appearance of an episcleritis. All we did for him after we picked up that stain was to stop all the toxic medication and give him bland lubricants, and the surface healed itself completely, and he was very comfortable. So just like recurrent corneal erosion, sometimes recurrent conjunctival SPKs may need to be considered as a differential in situations like this. So with that list of differentials, I close my presentation. Thank you very much for having me here.
Oh, that was an amazing talk, Radhika. We truly covered every imaginable possibilities.
Thanks, Dr. Chitra.
Very exhaustive talk, madam, no doubt. I mean, every DD possible was covered. Coming to the possibly the most common cause for recurrent SPKs, which is post-adenoviral, which we keep seeing patients coming. Two specific questions. Your thoughts on initiation of povidone-iodine therapy in the acute phase, and in the later phase, how do you use cyclosporin, tacrolimus, and PTK for treatment of recurrent SPKs and eventual scars?
So regarding povidone-iodine itself, there is a lot in literature about povidone-iodine in the early stages of SPKs. I feel that if at all it has any role, it has a role in superficial bacterial keratitis and adenoviral, because povidone is a contact sterilizer. It treats where it touches. So in any other form of keratitis with deeper involvement, povidone will not have any role. But adenoviral being self-limiting, there is a possibility that it can heal on its own. It's a pretty stinging medication to use. So that is the only downside of using povidone. But if the patient can tolerate it, it can definitely be tried. And regarding the later part of the disease, there are some definite indications for starting steroid, which unfortunately are not followed very often. Like I pointed out in my presentation, there is a blink and miss stage where you have subepithelial infiltration. So if that happens in the center of the cornea and the vision is less to about 612 or so, and the patient is symptomatic, then there is no choice but to initiate steroid therapy. The other indication being when you have a lot of pseudomembranes, there again, you know, the inflammatory component is very high. These are two situations you have to initiate the steroid. You can monitor and taper it as quickly as possible, but it's easier said than done. And more difficult is the situation where somebody else has started steroid in whatever stage of the disease, the patient comes to you, keeps on throwing up those SPKs when you taper the steroid. I find that that is the kind of patient in whom I instill what is called as a very slow taper. A very slow taper where I bring it down to once a day, and then if it recurs after stopping there, then I bring it down to say alternate day for 2 weeks, and then twice a week for a month, and then once a week for about 2-3 months, so that I hope that I can keep the virus at bay but not incur the side effects. And when it's down to that kind of a slow taper, I start tacrolimus ointment 2 times a day, hoping again that it will take over from the steroid. And I should say that I've not always, but had a fair amount of success with this kind of an approach.
Thank you very much, Radhika. Dr. Somshila and Merle, before you all go off to sleep, I'm going to ask you, what would be your recurrence-free period before you decide to do a PTK for the scars? Dr. Merle, Dr. Somshila?
Hi, yeah, so probably at least 3 to 6 months is what we'd wait for, because if you do it sooner than that, then I think I've not tried it sooner than that, but I think at least 3 to 6 months of quiescence, and having patients on cyclosporin or tacrolimus prior to that without any recurrences is something that we would actually hope for.
Okay.
Yeah, I would say the same. Yeah, I would pretty much agree with what Merle said.
You have anything important to add on this particular, something very relevant topic?
But that said, I think most of the scars, most of the time post-adenoviral scars, if they're not meddled with, they go away completely. So I think we should give a window, a long enough window for that happen before we decide on therapeutic.
Yeah. I was just going to say the same thing, that the terminology, they're not really scars, I feel, because they shape shift. And if you wait long enough, the shape would be different. So there's a lot of remodulation, or perhaps there's some inflammatory component which goes away. So we would really wait on these scars for a long time and we'll document serially, so that you know for sure that they are actually exactly the same, like 3 months, 6 months, and then go ahead with especially if the patient's vision is very symptomatic. Patient is very symptomatic for poor vision.
Anything to add, Shreesh?
Yeah, no, this is regarding povidone iodine in the early phase of the disease, that is during the early stage of viral conjunctivitis. It actually has a role in the lower concentrations, maybe around 0.1% if you can prepare and give. And if they use it 4 times a day in the initial phase, the chances of those subepithelial infiltrates, the development of this subepithelial infiltrate is reduced actually. This is our observation, and we have been doing it in a few cases, selected cases, and the chances of subepithelial infiltrates developing, it actually reduces the viral load in the acute phase, and it can be tried in patients.
Dr. Merle, you have
to reduce this subepithelial infiltrate formation.
It's a grossly underutilized substance. I mean, there's a lot of literature already available. It says that 1% as well as 0.5% has been effective in reducing the incidence of subepithelial keratitis. But somehow, because of lack of availability of a directly formulated drop and having to mix a variety of reasons, this has not been taken up in a large way by most of the corneal as well as general ophthalmology.
If I could just add a point, see, even if you look at adenoviral, the SPKs are actually words in the eye which was affected first. And the reason is your bacterial load or your viral load was much higher there. By the time the second eye gets affected, you have some amount of natural defense mechanism which is already set in. That's why you will always, the best way to earn the trust of the patient would be to just see him and then tell him, oh, it started in the right eye first or it started in the left eye first. The moment you tell that, they feel that you have hit the nail on the head. So that also indirectly tells us that we need to kind of reduce the load of the bug as quickly as possible. Apidine does have a role. The only problem is the toxicity in terms of they're already so symptomatic that sometimes they are not ready to instill the medication. Sometimes when the patient comes to the OPD, we just instill 1 drop in the OPD and send it. But then asking them to use it, unless the 1% is available or you compound and give it, might be too irritating for them. And if they end up with an epithelial defect or something, that kind of complicates the matters. But the study with the dexamethasone and povidone iodine smaller concentration did definitely show an improvement with respect to the SPKs.
Thank you. Any thoughts? Shall we go on to the next talk then? Okay. We have our next speaker, Dr. Bhaskar Srinivasan himself, who's a senior consultant, the Cornea department at Shankar Nethralaya, has great interest in the ocular surface diseases. And he's going to be talking to us on management options in recalcitrant VKC. On to you, something again very important to all of us.
Thank you, ma'am. I'll just share my slide. Yeah. One second. Is my screen seen?
Yeah.
Yes, sir, but it's a blank screen as of now.
1 second. 1 second, sorry.
Yes, sir.
So a very good evening, and I'll be speaking on recalcitrant VKC and the management options, no financial disclosures. So basically, we look at the classification of allergic eye disease, look at the clinical features, grading of VKC, and look at the complications and the medical and surgical measures that we might be required to take in these cases, and look at some interesting cases. So allergic eye disease is a very common condition, and generally you can have a genetic basis to it. You could have pollution, which could cause most of the cases that we see in India. And if you look at classification, obviously you know it's seasonal, perennial. You have VKC, AKC, GPC. And here today we are going to be talking about VKC, and we're going to be specifically looking at recalcitrant forms of the disease. In general, VKC is defined as a chronic bilateral allergic eye disease, which affects the pediatric age group primarily. But we now know that it can persist in adults, and sometimes you can also see what is called as an adult onset VKC-like disease, which is a newer description. It could either have a tarsal form, a bulbar form, or a mixed form of the disease. And when you're looking at clinical features, itching is the most important symptom that a patient with allergy would give, apart from all the other non-specific complaints that the patient gives. When you're looking at clinical features, papillae, whether it is in the tarsal conjunctiva or whether it is at the limbus, are one of the most important signs that you would see. Apart from the presence of Horner-Trantas dots in active disease, you can also look at perilimbal pigmentation as a sign of a VKC disease activity. And what we are all worried about is corneal epitheliopathy or changes secondary on the cornea, secondary to the severity of the allergic eye disease. And obviously, we're looking at complications such as limbal stem cell deficiency, keratoconus, or the complications due to medical measures in terms of glaucoma. So when you're looking at tarsal papillae, you can grade the papillae less than 0.3, less than 1 mm. But what we are more worried about is if the papillae are huge, and they are called as giant papillae when they are more than 1 mm in size. And when you have multiple confluent papillae, they can have what is called as a cobblestone appearance. And when you have pseudomembranes or discharge sticking in between this papillae, it's what is called as a Maxwell-Lyon sign. If you're looking at a tarsal papillae and you stain it, and if the surface of the papillae is staining, it indicates a bit of an active disease. Just like when you look at Horner-Trantas dots, the apex of these nodules will actually stain. Similarly, when you're looking at a tarsal papillae, if the surface stains, it indicates an activity. If the surface is smooth, it indicates it's an inactive phase of the disease where you might not have to treat it much except for the cosmesis in terms of it causing lid ptosis as such, if it is huge. When you're looking at a limbal papillae, it can sometimes be gelatinous in a confluent area, which is called as a pseudogerontoxin. And what we just described about in terms of Horner-Trantas dots, you can see these whitish excrescences at the head of the limbal papillae, which are basically eosinophilic accumulation as such. Perilimbal pigmentation was described by Dr. SKR as one of the signs of VKC. So when you're looking at corneal involvement, which we are all worried about, because that's what finally affects the vision of the patient, it could either lead to punctate erosions, it could lead to coarse epitheliopathy, and it could lead to macro erosions. And Bonini and our own Nikhil Gokhale has given a classification with respect to VKC. In Bonini's classification, you're basically looking at quiescent, mild, intermittent, moderate, persistent, and then severe, very severe, and in an evolutionary phase where it's basically a burnt out disease. So what we are basically worried about when we say a recalcitrant is anything which is worse than grade 2B, which is moderate and persistent. Anything which is moderate and it's intermittent and it settles down with your topical anti-allergics or a short course of topical steroids, you're probably not worried. But when you are not able to get the patient off topical steroids, or the severity or the frequency is such that you're worried about visually significant complications, then that is what you would label it as a recalcitrant VKC as such. So when you're looking at the Nikhil Gokhale's publication in IGO, he's also probably looked at it in the same manner, grading it as mild, moderate, chronic, and severe and blinding. So obviously anything in the blinding group comes under recalcitrant. Everything in the severe and the moderate chronic comes under recalcitrant. And what are the features that come under moderate and severe is primarily whenever you have limbal deficiency, when you have severe corneal involvements in terms of a shield ulcer, or you have corneal scarring, pannus, conjunctival granulomas, which are large. So every time that your cornea is involved on a more repeated basis, or it is visually threatening, is something that we are going to be concerned about, and we would want to avoid that or address it as best as we could. Sorry. So when you're looking at managing allergic conjunctivitis, you have the option of medical, surgical, and desensitization. I'll probably stick to medical and surgical because my experience with desensitization is very, very limited as such. So when you're looking at management protocol, which Nikhil has mentioned in his paper, again, you start off with avoidance, then you go off to lubricants, then you go into mast cell stabilizers, you go to pulse lotepredinols, and once it doesn't respond to that, you go to higher frequency steroids. If it is recurring, once your steroid is stopped and you want to get the patient off topical steroids, then you would go on to a topical cyclosporine or topical tacrolimus. We found topical tacrolimus to work much better. At least the tolerance is much better than topical cyclosporine 2% as such. For further complications in terms of severe tarsal papillae which need treatment, you might want to consider supratarsal steroids. But when you're giving supratarsal steroids, you need to be careful that they don't develop glaucoma secondary to the steroid. And in certain cases where, in spite of all the efforts, it is not settling down, you might want to put the patient on systemic medications. It could be a short course of systemic steroids. But if it recurs again, once the systemic steroid is given, you can't keep the patient endlessly on systemic steroids, whereby you might want to consider systemic immunosuppression. In systemic immunosuppression for allergy, cyclosporine or tacrolimus is probably the drug of choice at this point of time. Again, when you're looking at VKC versus AKC, the role of systemic medication is much more established in AKC as compared to VKC as such. If you develop corneal problems, then you are looking at a shield ulcer management which will be coming to subsequently. And when you have very large giant papillae, you might want to consider excision. Again, I'll discuss that later. So looking at the complications, I'll probably be focusing more on shield ulcer amongst the list of complications here. So when you look at shield ulcer, the grading is when the shield ulcer is the epithelial there is an epithelial defect, but the base is clear. Where there's an inflammatory debris at the base, it's grade 2. And when you have elevated plaque at the base, it's grade 3. Why is it important to know the difference is if there is an elevated plaque, it's not going to respond to just medical measures. You will have to debride the elevated plaque so that the epithelium is able to grow across that area and cover it. It's generally described as an oval or a pentagonal lesion, which is superficial, and it's located nearly close to the visual axis. And why are we worried about it? Because it could lead to a corneal scar, it could get secondarily infected, and ultimately could result in a decrease in vision. So this is the picture showing the various grades. A grade 1 where the base is clear. There's still it's slightly growing from a grade 1 to grade 2 because this part the base is clear, this part the base is translucent. This is a grade 2 where the base is translucent, and this is a grade 3 where there's an elevated plaque sitting at the base. So here you will have to debride it. Only then will the ulcer heal. How do you treat a shield ulcer? If it is a grade 1 or a grade 2, you might want to put a bandage contact lens. You will start a treatment with topical steroids. Look for the healing. If it doesn't heal in a week's time, you might want to take the patient up surgically for an amniotic membrane for facilitating the healing. For a grade 3, you will have to debride it. You could debride it and put a bandage lens and start the patient on topical steroids. Or if it's a child and you're anyway taking the child under general anesthesia, you might actually just put an amniotic so that it facilitates a faster healing of the epithelium. So this is a patient with AKC who presented with a shield ulcer, and we put her on a bandage contact lens because it looks like a grade 1. We put her on a bandage contact lens, hiked up the topical steroids. We sent her to the dermatologist to start her on systemic tacrolimus. The defect did not heal in a week's time, so we had to do an amniotic membrane. But after that, she was stable. So you need to, in certain situations, you need to use systemic medications to control the allergic process. So coming to GPC per se, you have the treatment options are topical steroids, immunomodulators, systemic steroids or immunomodulators. You could use cryo to be applied to the papillae. You could use supratarsal steroid injection. And the last one, which is not very commonly used, would be excision along with mitomycin or along with an amniotic membrane or along with conjunctival autograft or along with mucous membrane graft. So we've tried excision with amniotic alone, where our results were not very good, even though Amit Kherka's group has published a fairly good result with excision of the papillae with amniotic membrane alone. Paulo Dantas et al. Have excised this giant papillae and replaced it with bulbar conjunctiva. We were a bit concerned with using the conjunctiva more because the bulbar conjunctiva is also exposed to the same allergic stimulus that the tarsal conjunctiva is exposed to. These are eyes who might require further surgeries as far as glaucoma surgeries are concerned. So we didn't want to touch the conjunctiva as such. And histologically, the conjunctiva is probably going to behave in a similar manner. With our experience with mucous membrane grafting for lid margin keratinization in MMG, we thought it might be easier to excise these papillae and replace it with a buccal mucous membrane graft. The advantage being histologically, mucosa behaves differently. It doesn't have the same allergic tendency as for VKC kind of a response as compared to a conjunctiva. And whenever we have done a mucous membrane graft in these eyes, there has not been any recurrence of papillae in that area of the mucosa, because histologically it doesn't have the septae and doesn't behave in a way that it is going to give rise to a papillary formation. You will see beyond the area of your mucosa that you have done. Cosmetically, it doesn't cause a blemish, and immunologically also, mucosa is supposed to be having some kind of an anti-allergic properties as compared to conjunctiva. So we're looking at certain case scenarios now. So this was a patient with a grade 2B Bonini's classification, mild disease. Horner-Tantas dots will do well with dual acting medications. If the Horner-Tantas dot doesn't respond, you might give a short course of topical low dose steroid. Whereas with a grade 3 with a persistent symptom, you can see the staining of the tarsal papillary papillae also. There are Horner-Tantas dots in the limbus also. So this patient was started off with topical steroids and olopatadine and then maintained on topical tacrolimus to reduce the dependence on topical steroid. Another patient with a grade 3 to 4 with significant corneal changes also and with keratoconus. Here it is important to control the disease activity with topical steroids first, add on topical immunomodulators. Once the disease is under control, then you tackle the keratoconic component. He underwent a lamellar keratoplasty in one eye and a cross linkage in the other eye. Another patient with a significant limbal stem cell deficiency, no other systemic ailments, was on all medications. It was getting worse. He had to shift or relocate to a different place. And finally, that is what actually helped him, because after shifting from that location, his eye became a lot more quieter. There was the episodes of allergy became less. So even though it might not be practical in all cases, sometimes getting a history as to where does he get his exacerbation from can make a difference in managing the disease as such. This was a patient with very severe grade 4 VKC with a shield ulcer with systemic atopy also. And he underwent a debridement with amniotic for the shield ulcer. We had given supratarsal steroids. We reviewed with the dermatologist who changed the tacrolimus to picrolimus skin ointment. He was also given systemic inhalers which contained steroid for his rhinitis. So probably the combination of the inhalers and the change in picrolimus, from tacrolimus to picrolimus made a difference. But when you study literature, both seem to work equally. There's no significant difference, but there are some studies which say that for atopic dermatitis in certain situations, picrolimus works better than tacrolimus as such. Again, a patient with severe VKC with tarsal form of VKC, you can see the ptosis. For him also, we had done the maximum medical measures. We did cryotherapy and supratarsal steroid. You could see a decrease in the papillae. And then after again a couple of months, there was a recurrence. Gave oral steroids. It quite settled down. Again after a few months, recurrence. And then when we finally did an MMG for him, after that now it's almost about 4 years, there has not been a recurrence of the papillae, and you can see the smooth surface indicating the lack of mechanical irritation that will cause on the ocular surface. So it's not that it is the first choice. It's only once you finish all your armamentarium that you have and it is still not getting under control, then you are left with two choices. Either put the patient on systemic immunosuppression or you excise the papillae and manage it locally. We thought we should first give a chance to a local management before deciding to put the patient on long-term systemic immunosuppression. Another patient with a grade 4 with very large papillae. Again, and in fact, in 2 weeks, you can see that the eye is significantly quietened down. And the patient who required systemic steroids to even allow us to evaluate the child in the OPD was walking comfortably in the OPD with the eyes open. This is the other eye of the same patient, showing how the oculus of the impact of this kind of a papillae on the ocular surface is something that you all would be able to understand. This is another subset where we have seen that in patients with immunosuppression. So this boy was a 12-year-old boy with HIV since birth. And when you have a worsening of your immune status, you tend to have a worsening of the allergy as such. So if you have an adult onset patient, or if you have your VKC which is not getting controlled, kindly check the immune status of the patient. So the moment the CD4 counts improved, this patient, the allergic symptoms were a lot easier for us to control. So this is what is labeled as the Th1, Th2 immune shift. This was another adult onset mixed VKC kind of a disease patient who was around 30 years old, and he had his history only for the last few months, on and off topical prednisolone. And again, once he had stopped his heart. Once you go back to the history, if you can find out if he's not, then get an HIV test done to be sure, because it's not common to have a VKC at an adult onset disease, even though it's a described phenomena now. But if it's not getting under control with conventional measures, it's looking atypical with respect to age of presentation, then check the immune status of the patient. And once the immune status improved, the allergy significantly settled. And this is what we published earlier. This was a child with VKC with severe corneal involvement with molluscum, and he had to be shifted to a third-line heart. Until he was shifted to a third-line heart and the immune status improved, we couldn't get him off topical steroids at all. And if you look at the eye, it looks almost as if there's a complete limbal deficiency. You can't make out anything about the anterior chamber details. And this is the same patient almost now 12 years down the line. His vision has improved from the counting fingers when the picture was taken the last time to around 6/18. With pros, he's improving to 6/7.5 in both the eyes. And his disease is under control more because his HIV status is under control with the third line regime of heart. Thank you.
Thank you. Thank you, Dr. Bhaskar. There was nothing left. You gave us a beautiful, thorough picture. Thanks so much. I'm going to ask a very basic question, and Dr. Merle, can you take that? Like, what would be your timing of doing cross-linking? I mean, they are a patient with keratoconus and they have VKC. So when would you do cross-linking? What would be a time frame, and what would be under cover of what?
So usually so this is like a kind of a devil in a deep blue sea situation, because you have patients with active allergy who have keratoconus, who most likely are going to have borderline corneas, and you need to cross-link them fast. So I don't think there's any magic drug that we would use. We usually put patients on topical steroids, give them a quick course, put them on mast cell stabilizer. My personal favorite, and what I found has been very effective, has been Cromalfort, that is sodium chromoglycate 4%. As opposed to the dual action drugs, I found that in kids, Cromalfort works much better. While in adults who have allergy that comes in, usually we get a good effect with either olopatadine or something, alcaftadine or something like that. But I've not had that good experience with Cromalfort with with these drugs in children. So that's what we put them on. Then we add the tacrolimus and make sure that these patients have at least 3 months of quiescence. There has to be less inflammation on the eye, and then proceed with cross-linking in that scenario.
Yes. Yeah, if I could just add, because if your cornea has issues with the allergic eye disease itself, the basic test that you're going to do to look for progression itself becomes inaccurate.
Yeah.
So you need to treat the disease first in terms of your allergy, make sure that your cornea is clear, then get your topography, because that is going to be your baseline for you to compare whether there's progression or not. And then maybe 2 or 3 months of the eye being quiet, I might want to just continue the low-dose topical steroids and or put him on topical tacrolimus during the period to make sure that it is quiet. Second, when we are doing the cross-linkage in these eyes, my threshold to take the patient up into the OR to do an amniotic is going to be much lesser. So by a week's time, if I feel the defect is not healed, because normally you would expect it to heal in about fourth or the fifth day latest. By a week, if it has not healed, I might just take the patient up, put an amniotic. I don't want the cornea to be deepithelialized, leading to a haze or a scar, which adds on to our problems in the postoperative visual recovery as such.
Sir, one quick question. Your views on using systemic cyclosporin in VKC patients where they don't really have systemic atopy, because systemic atopy generally a dermatologist is taking care. But what subset of patients would you use systemic cyclosporin as a steroid sparing agent?
So, I mean, this has always been a debate in a sense. If you look at the LVP publications, they go more by systemic immunosuppression. So the group in VKC that you're going to be looking at systemic suppression are primarily patients with giant papillae who end up with shield ulcer. So if there is no other systemic issue which is there, we would probably look at targeting the papillae surgically. If it recurs after that, we would put the patient on systemic immunosuppression. The other school of thought would be, I don't want to take the patient up for surgery, because even with steroids, when you give it for a short period of time, you do see a recurrence of, you see the papillae reduces. So the idea would be, okay, I don't want to subject the child to a surgery, but I'm okay with monitoring their side effects of the tablets, and I would put them on systemic. So it's not that this way is right or that way. We felt if your local problems are more, and it is something which we can address locally, I don't have to subject the child to these medications, because again, you're going to be keeping these medications for at least a year, year and a half, and then you're going to be tapering or stopping the medications at that. So you're not looking at 1 month or 2 months of systemic immunosuppression. You're looking probably close to at least 2 or 3 years till they reach a pubertal age where you feel the disease itself, intensity itself is kind of coming down, and you are able to stop it as such.
So you would prefer in an active GPC with a mechanical effect, you would rather side towards a mucous membrane.
No, that's why I said it's not that all GPCs require surgery. Even if you have a very large papillae there, but the surface of the papillae is not taking up stain, your cornea is not taking up stain, then the only reason for excision, if at all, would be a cosmetic ptosis which the papillae is causing, which you have to discuss with the patient whether they want it to be done for that. If that is not the case, then most of the times, once you're with tacrolimus and with, at least with tacrolimus, we've been able to control most of it. Even in SN, for that matter, over the last almost like 18 years or so, we've done a papillae excision only in 13 patients. So it's not something that we would advise right, left, and center. Even if you look at LVP, the number of patients who have to be put on systemic immunosuppression is a small subset. It's not like a huge subset. So you're talking about using it only when you are not able to control it with local measures. To a large extent, tacrolimus has been a boon for us, because that has significantly reduced the need for us to do anything more.
Thank you. We shall now go on to our next.
To add one thing, I think Bhaskar pointed out many aspects. But I think in VKC and in the pediatric age, which presents with the limbal form, we talked a lot about the giant papillary form. The limbal form is the one which is very difficult to manage, because quite often it leads to encroachment into the visual axis, and you end up, having a panel sort of. Those cases, I think the management overall has been to look into the absolute eosinophil count and serum IG levels. If that is high, they actually are sort of controlled with Montelukast. The other thing is that immunosuppressants should be sort of required, should be a mandate for those patients who go into a perennial form of VKC. Because even though it may not be, you start with a very low dose, like something like what you start in RN, very low dose. And then the frequency of recurrences I've seen in my experience, they come down a lot. Like it will not tide over the acute crisis which happens, but the frequency of recurrences which happen, that is sort of settled with the perennial form. So I think the limbal form, I think, is equally dangerous than the papillary form. Which we have.
The limbal form will end up with a limbal deficiency as such. So, and you can't go ahead and excise it or do anything for it. So you will have to put the patient on topical. And if it is not responding to that, you might want to put the patient on systemic immunosuppression to control, because there is the inflammatory component which is damaging the limbus. You need to protect it as best as you could. Sometimes what we assess as like I showed the picture, what initially when you looked at the picture, you felt that there is actually a limbal deficiency in the last photo that I showed of the HIV patient as such. But once the inflammation comes down quite a bit, there is probably residual cells which kind of take over, and you are able to establish it. So those kind of patients, yes, you will probably need to give immunosuppression to kind of control the disease. So you will have to, it has to be there in your armamentarium. You need to be wise when you would want to use it. And if you're going to be using it, you need to be very clear with your follow-ups and your side effect profile that you will need to manage.
Thank you.
If I may add something.
Yes, Dr. Vanandi.
Yeah, so I think fantastic discussions here. And as rightly pointed out, it's going to be the morbidity of the disease which is going to decide on our stepladder approach and what we introduce when. And we did look at the use of, topical tacrolimus eye ointment, 0.1%, which I now have started using over the lids of these children. Because these children, tacrolimus is very irritant to the eyes, and children do not tolerate it when you use it into the conjunctival fornix as compared to cyclosporin here. So I use tacrolimus ointment 0.1% on the lids of these patients, and I find even the GPC resolves well, but then the result is not dramatic. You probably will have to be long drawn depending upon the severity of the GPC you're looking at. So the decrease in the GPC severity could be anywhere starting from 2 to 4 weeks or 6 weeks here, but then definitely starts becoming quiescent, and most of my patients are doing well. And this is a good alternative to taking the patient to the theater more frequently. I keep it for a longer period of time. The lid edema, the lid inflammation all goes down, and the patients become more quiescent and they are more tolerant to the therapy. But then again, it's only effective as long as they are using it. I have patients, once they stop using it, and those who have a propensity for frequent recurrences, it starts occurring. But then this is probably an alternate therapy to putting a child on a systemic immunosuppressant therapy long-term. You have those moderate to severe cases where you're still thinking, do I need to push the child into a systemic immunosuppressant? So where a trial of this works, and then you could keep it on for a long period of time, it perhaps helps to save that bracket of patients rather than pushing them into systemic immunosuppressant therapy. So that's something which we did find, and we looked at tear tacrolimus levels after therapy for these patients. This is probably going to come out in the next issue of Cornea as well. And this I do find is a good alternative and works well in pediatric patients. It also works well in those patients with VKC, where you want your ocular surface inflammation to be as low as possible before you want to do a C3R for these patients.
Thank you, Dr. Vanandi, for those inputs, and Bhaskar, thanks so much. We go on to our next speaker, Dr. Praveen Krishna, who's the director of and head of the refractive cataract and contact lens services. And of course, we all know he's an amazing speaker, and he's going to tell us exactly in his time duration every possible thing which we need to know. And his talk is going to be advanced KC with apical scarring, big bubble versus manual talc. Yes, Dr. Praveen. We always keep the best for the last.
Thanks a lot. Yeah, but yeah, so what I've done is, because I'm in the car, I just recorded my talk 15 minutes back so that I won't keep you waiting for too long, and also you won't have noise of the traffic. So I'll just play the recorded talk and then we'll have a discussion. Is that all right?
Yeah.
Okay. So let me. So.
We made it all very late, I know.
So that I'll be able to measure myself from the perspective of time a little better. And I'm sure it's pretty late. So first of all, thank you very much, Dr. Chitra, for having me on this platform. It seems that you've been able to put together some very engaging programs, and I'm very glad that I've been a part of these programs, and I'm also very happy that several people seem to be benefiting out of them as well. So in addition to all the great talks that you've had today evening, what I'm going to be speaking to you today is about a topic which is titled Advanced Keratoconus, whether we're going to be doing a manual DALC or a big bubble DALC. So what I have done in my presentation is I've taken the liberty to go a little beyond the mandate of what I've been given from the perspective of just advanced keratoconus, talk about manual DALC versus big bubble. but talk a little bit more about the planning for a patient who has keratoconus before we take them up for dialect surgery, and more specifically towards the end of the presentation about what we will do when you have somebody who has apical scarring or maybe even deep stromal scarring. So in the sequence of steps, what I've divided my talk into is 6 steps. I'll probably not talk too much about the 6th one, but the first 5 are very relevant to our topic, to our title today. So in surgical planning, there are 5 things that we have to ask ourselves before we do anything in a patient with keratoconus. So firstly, if the endothelium is normal. Second, if there's a previous history of any surgical procedures that have been done, what level the pathology extends to. This is very specific about the topic today. What is the potential visual outcome that we can expect, and what dissection technique we'll prefer for what kind of case. So first up, and I'll be quick about this, is to assess if the endothelium is normal or not. And the reason I say this is because nowadays, with the advent of cross-linking, we have been seeing several patients who are having complications of cross-linking, like corneal melts, chronic corneal edema that tends to resolve with time eventually, and also result in anterior stromal scarring, as you can see here in this patient. What is interesting is, though eventually these patients resolve to form a scar, which appears like this. In fact, this is a patient who had post-corneal, post-basic ectasia, who then developed this corneal edema and then scarring and then epithelial ingrowth, a very complex looking picture. But what is interesting about these patients is the fact that if you're able to do an endothelial cell count from the periphery, several of these patients have low endothelial cell count. So it is not a good idea to do a DALC in these patients who have low endothelial cell count. So it is important, before we do a DALC, to answer the first question, whether the endothelium is normal or not. And the same thing applies for somebody post-eye drops. Would be a good idea, if you can, to get a peripheral specular done. The second important aspect of pre-op evaluation is to ask about prior history. And nowadays, with collagen cross-linking again being widely available, a lot of patients tend to have collagen cross-linking with the mistaken understanding that it's going to improve their vision. And when it doesn't, or when they have scarring or other complications, they come in for a DALC because their contact lens intolerant. And knowing this history is useful. It is not very, very important, but it is useful because the dissection technique and also where you will inject your bubble will also vary when you're doing a DALC. The pattern of the air bubbles also tends to be a little different, because it seems as if the stroma is more compact and you will have less emphysema in the anterior stroma. And it also seems that anecdotally, I've seen that getting a bubble has been a slightly more of a challenge in patients who have had prior collagen cross-linking as well. The next thing that is important to ask the patient, again, very quickly, we'll just go through this, is about the potential visual outcome. And this is where the level of the scarring or the pathology that we're going to discuss more in detail is important. So if you have somebody who has a scar that is there in the visual axis and you expect to take it off after DALC, it is important to determine what level the scar is. Sometimes if the scar is posterior stromal, like you're seeing here, you might end up leaving some of the scar behind at surgery, especially if you're doing a manual dissection, as you can see in this patient as well. Majority of cases, this does not hamper visual acuity to a large extent, but it does reduce visual acuity by about a line or two. And this patient had 20/40 best corrected with that post-op posterior stromal scar. But what is more important for us today is to determine what level the pathology extends to, or what level the scar is at in the eye. And there are 2 basic kinds of scarring that occur in keratoconus that you will be seeing, especially if you're planning to do a DALC surgery. The first kind of scar is scarring that occurs at the tip of the cone, and this is typically called apical scarring. And this kind of scarring occurs because of stretching of the anterior stromal lamellae breaks in the Bowman's membrane and the epithelium going in between the Bowman's membrane and leading to this scarring that typically occurs at the apex of the cone. And the second kind of scarring is scarring that occurs deeper within the cornea, which also can occur because of stretching of the lamellae. But the prototype of this kind of scarring is typically scarring that occurs because of hydrops. Now, how do you differentiate the two of them? Typically, apical scarring, like I said, always occurs at the apex of the cone, and apical scarring will also result in some flattening of the cornea. And the pathognomonic sign of apical scarring is the fact that on OCT, you will see a divot on the stroma, and you will always see a thickening, a significant thickening of the epithelium overlying that. So if you do just a Scheimpflug, you will get an erroneously thick cornea, but actually the cornea in this central area is extremely thin. It's probably about 170 microns, whereas the rest of it is the epithelium. So your surgical technique needs to vary as well. Sometimes this apical scarring, as you see here, tends to extend posteriorly as well. And as you can see in this OCT, the scarring is indistinguishable from the posterior layers of the cornea, including the predesmase and the desmase membrane, which is where you have to pay a little more attention to your surgical technique. So, but what is important is, like I said, this kind of deep thickening of the epithelium will determine whether this is apical scarring or not. Now, the second kind of scarring that we're confronted with in patients with keratoconus is the scarring that typically occurs after resolved hydrops. Again, tends to occur at the apex of the cornea, but not exactly the apex, can be anywhere in the surrounding areas. And the difference in these two is not very much if you're going to be looking there at them in a broad beam. You'll have to make a slit and probably do an OCT to find the difference between these two. And on OCT, typically you'll find scarring that is multi-level, that it is present at multiple levels. And you'll also see that scarring is very close to the predesmase and desmase membrane. And it probably in some areas is indistinguishable from these layers. Epithelium is thickened in some areas, but not to the extent that you'll see with apical scarring. So that is how you differentiate apical scarring with deep stromal or post-hydrop scarring in keratoconus. Now, how is this important? How is this information important? This information is important because the level of scarring will determine the kind of surgical technique or the dissection technique that you will use during your surgery. So how is this important? Well, this is important because, say, for example, if there is a patient who has a prior history of hydrops, as you can see in this patient, with pigment dispersion all around, and you plan to do a big bubble, you're not going to be successful in this kind of surgery because typically the desmase membrane and the duas or the predesmase layer do not have enough strength, especially after resolution of a recent hydrops, because they have not relayed the desmase membrane again, and you will have to do a manual dissection. Manual dissection, typically you will be to a posterior stroma along with addition. Usually you get 2020. As you see in this video, you will typically begin with debulking the cornea because debulking the cornea seems to increase the potential chance of getting an air bubble because of the fact that you are more likely to be in the posterior stroma when you inject your air. Now, this is a case of a normal case of keratoconus without apical scarring. So in this case, what you will do is what I've done here is I've debulked the cornea and then I'm using my sharp bar blunt dissector to go into the stroma and then injecting air into that tract. Very typical of most DALs. And you'll see that I'm going to get a big bubble right in the center. It's starting to form right now. Little emphysema in the periphery, but it's starting to form. And then you see that the bubble in slow motion actually spreads very nicely and in a very controlled fashion as well. Now, what will you do when you have apical scarring? When you have apical scarring, do not debulk, because if you debulk, then as you saw in the OCT, you might make the central cornea so thin that there is not enough stroma to retain the amount of pressure required to generate an air bubble. So in cases of an apical scarring, I will go and inject my air bubble right away. And as you can see here, we're getting a big bubble, not very evident, more emphysema, but we've gotten a big bubble. And then after that, then debulk the cornea, because if you do it beforehand, the likelihood of you getting a big bubble is much lesser. And that is why apical scarring is important. What do you do when you have a deep stromal scar? Deep stromal scar, again, you have to differentiate whether it's a post-hydrops or a non-post-hydrops scar. Difficult in some cases very evident. But when you don't see any discontinuity of the desmase and the pre-desmase layer, it might be because of the fact that this is a posterior stromal scar and not a hydrop scar. But if you have a post-hydrop scar, what might happen, or a posterior stromal scar, what might happen is your air might not spread and separate the desmase membrane from the posterior stroma. And as you can see here, we're not getting a bubble. So I'm trying to debulk this anterior part of the cornea to see if I can inject the air again. And I'm trying to inject the air again and see what happens as I try to inject. And this air is going to go very likely into a type 2 bubble, as you saw there. So the likelihood of getting a type 2 bubble in a case where you have posterior stromal scarring is much higher. And which is the reason why the chances of perforation also are higher in these cases. And so you've got to be really careful when you're using a bubble, especially a type 2 bubble in these cases. And even if you have a perforation, you can convert it into a type 1 kind of manual dissection. And you should be able to salvage these patients without too much difficulty. But then it's very important to recognize when you get a type 2 bubble and then when you put air and then you continue to dissect. The other problem with post-hydrops eyes is if you try to be aggressive in injecting your air bubble, you may get a pop in the desmase membrane and in the pre-desmase layer. And you will see here in slow motion and in ultra slow motion that very early on during the injection of the bubble, the air does not track to the side, but forms a type 2 bubble right away. And then it bursts and tracks inside the anterior chamber, leading to bubbles in the anterior chamber. And so in post-hydrops, please do not be aggressive in injecting air and try, maybe you can inject a few air bubbles to give you guidance about the depth. But if you're aggressive injecting air, you're going to have a perforation. The last bit is about sizing, but this again is not very important from our perspective today. But since we are talking about preoperative planning, I thought I'll cover it. Like if you have this patient with a very large, what appears to be a globus cone, what is important in patients like this is look at the pachymetry map to see where the cone actually is the thinnest, but also look at the tangential curvature to ensure that you're taking away all the cone at surgery rather than leave some of the cone behind. And also look at the white to white diameter. Here, the white to white is 13.1 millimeters. And in eyes like this, I'll try to take much larger grafts so that I'll be able to ensure that the entire area of my keratoconus is completely removed. And then try to take maybe an 8.25, 8.5 graft. Even with that, you see that this appears a little on the smaller side because of the overall large size of the cornea. But advantage is you can put continuous sutures and not go through the limbus, thus reducing the chances of having loose sutures in this case. If you have a smaller white to white, as you see in this patient, with a central cone, this patient has a white to white of 11.5. It is very important to ensure that you have centration, but you need to take a slightly smaller graft, typically about 8 millimeters. I don't go less than 8 millimeters in a patient of keratoconus. And then you can see that this appears to be a relatively large graft for this eye, but unfortunately might be difficult to put continuous sutures because of the proximity to the limbus. So I'll stop there, but just to summarize that in surgical planning for a patient of DALK who has keratoconus, it is important to first decide if the endothelium is normal and then ask about any previous history, especially about collagen cross-linking. Ask what level the pathology does extend to, because this is very important from your surgical planning, and what kind of visual outcome you're going to give. And very important, what level the pathology extends to will determine which dissection technique you will use. And finally, planning for sizing is also important because it has long-term implications, not just on the visual outcome, but also on the complications that you will have after surgery. So thank you very much for your attention. And I hope that you enjoyed this little bit of what I've learned over time, and the fact that the level of the pathology is important in determining the kind of surgical technique that you will use for that. Thank you very much.
Thank you so much, Dr. Praveen. That was a wonderful talk. Shreyas, are you there?
Yeah, wonderful, sir. I mean, masterclass in talc, and genuinely, I mean, I think the ASOCT pictures on the apical scarring, epithelial hyperplasia, I think they were extremely important points which all of us need to pay close attention to. While you were talking about when to use a big bubble and not use a big bubble, you also, I think, briefly hinted on having this kind of emphysematous small micro bubbles which help us guide the dissection. So if you're resorting to a manual technique, especially in a post-hydrops case, what are the steps that you take to ensure that you have a fairly uniform bed and not have a very irregular thickness? Because very often we tend to have a very thin in the center and a little thicker in the mid-periphery, which can lead to a lot of residual interface haze. So what precautions or what steps would you take, sir?
Oh, I think first up, nowadays, I probably would just do a PK in a patient who has a post-hydrop scar. I think two reasons why post-hydrops, the endothelial cell count actually drops, and so in lieu of PK. And I mean, recently I was listening to this lecture about the comparison in eyes with keratoconus and its outcomes of PK is about the same. To do a talc in a post-hydrops eye, I would rather just do a PK. Because several times we've had to leave behind scars that have reduced the potential visual acuity. But at least in the time that I used to do the surgery, I will still inject an air bubble, though not with so much pressure, because like you mentioned, the emphysematous air bubbles are great guides if you don't have intraporosity to tell you what level you've gone to and how much deeper you need to further dissect.
Wonderful, sir. Dr. Shrish Kumar, I mean, I have never seen him do a PK in a patient with eyes with keratoconus. So any difference in thought process, anything you want to add on this topic before we move on to Revati Madam?
It was a nice presentation, Praveen. A nice video demonstration of big bubble technique and manual technique. So I actually, my conversion rate has come down drastically after I started choosing my cases for manual talc and cases for big bubble talc. So cases with the apical scars, superficial apical scar or mid-stromal scars, I usually go ahead and do a regular big bubble talc. And many of the time, if it is a very deep scar, you end up having a type 2 bubbles or type 3 bubbles. So in such cases, I used to do a big bubble talc, continue with the big bubble talc initially, but the chances of perforation becomes more high in these cases. So nowadays, in such cases, I go ahead and do a manual talc. And in manual talc also, if at all there is a healed hydrop, if the scar is not central, if it is paracentral small scar, I go ahead and do a talc in these cases. And I usually inject air bubble in such cases also, just to create an emphysema in the peripheral cornea, so that helps us in the dissection. And as Shreyas rightly mentioned, it gives us a proper guidance, the level with which we can stop our dissection. So if you have an intraoperative OCT, you can go But if you don't have, this actually acts as a rough guide for us to stop our dissection. So these cases, like with the healed hydrops or very deep scars with the type 2 bubbles, I straight away go ahead with the manual DALK, and those with superficial scars or regular advanced keratoconus, where I get a type 1 bubble, I go ahead with the regular big bubble technique.
Thanks a lot, Shreesh. I think we'll have to go on to our last speaker. And Dr. Eyeedu has been so patiently there all through. Thank you so much, Dr. Eyeedu. And I think she needs no introduction. She's the chief of the Cornea and Refractive Surgery Services from Arvind Eye Care System, Coimbatore, and a veteran cornea surgeon. And she's going to take us to a very important topic. We seem to have kept it for the last: current concepts in recurrent HSP keratitis. On to you, Dr. Eyeedu.
Thank you, Dr. Chitra. And I was learning throughout the session, so no problem for me. I'm ready to wait. And I hope my slides are seen. Just to add a point to the previous talk, in such cases of hair scarring, I used to try the hydrodissection. I often talk about this, but I don't know, no takers for this somehow. Okay, moving on to my topic. Can you see my slides?
Yes.
Yeah. This is about recurrent HSV, which is the very common type of hepatic ocular disease. About 95% of it is only recurrent. And about 25% of the patients will get it in the first 2 years after the primary, and 63% in 20 years. If the primary lesion is a blepharokeratoconjunctivitis, then the chances for recurrence doubles. And in 12% of cases, it can be bilateral, especially even in children. And if the individual is atopic or immunocompromised by some reason, then the chances are really high. And the epithelial lesion, usually infective or neurotrophic. The stromal, usually the pathology is immune-mediated. Endotheliitis, iridocyclitis, both combined immune and infective pathology. The epithelial lesions, everybody knows dendro or dendrogeographic lesions, which will be appreciated well with the staining, double staining. And this should be differentiated from healing epithelial lesion, epithelial defect or effusion line, or an acanthamoeba perineuritis or a feathery fungal ledges. And the mainstay treatment here is topical, not oral, topical ganciclovir or acyclovir ointment in our part of the world where we don't have trifluridine. And both these drugs, they penetrate very well, but topical, they are more topical medications are good enough for surface lesions like epithelial lesions. Usually acyclovir or ganciclovir 5 times a day the first week. Usually we will start seeing some healing process. Then around the second week, we can reduce to 3 times and continue it at least for 21 days along with supportive therapy. And if it is not healing within a month, then we have to suspect the compliance or the drug toxicity and the trophic component. Very rarely even resistance can be a part of it. And what the first lesion here, what you see is the footprint where the lesion healed, only the subepithelial case. This is not an active lesion. We need not continue antiviral for this lesion. And metaherpetic or neurotrophic is a well-known problem in epithelial lesion, which has to be recognized. And because here we have to reduce or stop the antiviral and give low-dose antibiotic steroid to address the inflammation and to address the damaged basement membrane, and we can use amniotic membrane and also as a biological contact lens. And torsorrhaphy is the mainstay treatment here. The stromal part, interstitial keratitis is the most common, where the stroma will appear cloudy with keratic precipitates. Often this will result in scar, thinning, and vascularization. So it has to be addressed aggressively, and it has to be differentiated from acanthamoeba keratitis, and of late even microsporidial keratitis we have to rule out. And not only that, these two conditions can be coexisting in viral keratitis. That is more tricky many times. The treatment for stromal, being an immune-mediated lesion, basically steroid. And the main thing what we have to learn in interstitial type, this has to be tapered very, very slowly, as Dr. Radhika pointed out in severe VKC here. It should be, the frequency should be reduced 50% based on the response, but the duration has to be prolonged double. And as we do in uveitis, and very slowly we have to taper, and sometimes we may have to maintain them for a long time in very low dose, weekly once, like that. And whenever we use steroid, even in stromal lesions, we have to add prophylactic antiviral to prevent recurrence, especially epithelial recurrence, and the dose will be drop for drop. And this has to be continued for initial time when we use the steroid higher dose, and later on we can stop antiviral and continue low dose steroid maintenance. Endotheliitis, on the other hand, the stromal edema will be there, but the cloudiness will not be there. It can be just disciform or sectoral, or it can be diffuse, and sometimes may be severe enough to cause hypopyon and all. And here we have to, the mainstay here also steroid, but along with that, sometimes we'll give oral antiviral. And here we can taper steroid and stop faster than in stromal IK type. The necrotizing type is the most confusing one, because here it is a cytotoxic reaction which will present as necrosis. So it can be easily mistaken for a microbial keratitis, other of suppurative origin. And the recognition should be fast, because it can perforate very fast. And the herpetic eye disease study, though it is quite outdated now, very long, done long back, still some of its recommendations are being followed, especially on antiviral prophylaxis, oral antiviral prophylaxis in case of recurrent. When we call recurrent, it is 2 or more episodes within a year. In such cases, we can go for oral acyclovir or valcyclovir, which is a prodrug with better bioavailability. So the dosage can be just once a day and equally effective. And but when we come across, when we plan to intervene the resulting scar to give optical keratoplasty, to do an optical keratoplasty, or when we plan for any surgical intervention, intraocular surgical intervention like IOL surgery, we have to think in mind, we have to plan for topical or oral antiviral coverage in these patients. So planning keratoplasty, the lesion should be quiescent, ideally at least for 2 years, and antiviral coverage should be started well ahead, at least 2 weeks before the surgery. And usually I prefer valcyclovir, 500 milligram. In the initial period till I give higher steroid, I used to go for a BID dose, and later it can be a prophylactic OD dose. And vascularization has to be addressed with the diathermy or other mode of therapies. And corneal sensation should be checked. If it is grossly affected, better to avoid surgery in these patients. So the reactivation is very common in post-keratoplasty also, which is about 33%. And it can give a bizarre picture. Whenever epithelium is not healing or recurrently breaking, or on the host side, if you look carefully, you can find out that it is the viral epithelial reactivation. And endotheliitis also can occur in these patients, which can be very difficult to differentiate between from graft rejection. Then, of course, basically the therapy is almost same. We have to give steroid in both conditions, but in endotheliitis, we have to cover it with antiviral therapy also, where sometimes we have to go for very high dose of valcyclovir, 1 gram TID, and then it has to be tapered later. And neurotrophic problem in a graft also has to be kept in mind, and it has to be addressed as the neurotrophic lesion, where it can go for melt and perforation very fast. That's why it's better to avoid any surgery in these patients with where the sensation is grossly affected. So herpetic eye disease, herpetic keratitis, can it occur from the donor cornea? Not in our country, but where the donor cornea is organ cultured, then it can pass on the disease to the recipient. And coming to the summarization, topical antiviral is enough for primary blepharokeratitis or conjunctivitis or infectious epithelial keratitis, or as a prophylaxis whenever we are using steroid for the immune stromal keratitis. Topical steroid are mainstay for the stromal keratitis, disciform and endotheliitis also. but always we have to cover it up with topical antiviral also. Inflamed neurotrophic keratopathy also sometimes may need low dose steroid. Oral steroids are very rarely needed in viral, only in very severe diffuse endotheliitis or iridocyclitis with trabeculitis or late endotheliitis in graft. And the oral therapy only always a controversial. Actively, we have to give only in stromal necrotic or endotheliitis group, where valsiclovir 500 milligram PED or acyclovir 400 milligram 5 times a day will do. In immunosuppressed patients, it has to be given double the dose. Prophylaxis, it should be given as only in whenever we are planning surgical therapy, or we are going for prophylaxis, more frequent recurrent episodes are there, prophylactic therapy can be given. But acyclovir, we can also, like if it is even in recurrent conditions where we can't use due to patients who underwent renal transplantation and all, sometimes we have given only topical therapy also for a longer time. And maybe this also has to be proved. Acyclovir resistance also already published, and this is more in oral therapy. That's why we have to be very careful about giving oral therapy for a long time. And a word about zoster. Here, like again, a study is going on because zoster also can be recurrent and devastating problems. So whether efficacy of valsiclovir 1 gram per day for an year is being studied, whether this can be reduced. And both vaccines are not seems to be affecting the incidence of recurrence. And cytomegalovirus, just a word, this also recently recognized, commonly associated with endotheliitis. Whenever you come across unexplained corneal edema, where the endothelium otherwise is normal, or post-operatively in an uneventful corneal cataract surgery, you suddenly end up with a diffuse edema, or in case of non-resolving graft rejection, you suspect CMV endotheliitis. Ganciclovir is supposed to be the best drug here. Previously, only oral therapy was promoted, but being the cost, considering the cost, we can also use topical, because even at least in uveitis, topical ganciclovir also seems to be equally effective as oral ganciclovir. So in these conditions, we can think about using topical ganciclovir. Thank you.
Thank you. Thank you, Dr. Eyeedu. That was a wonderful, very crisp talk. Dr. Merle, I would want to take a question from you. You're there? Dr. Merle. Dr. Sunita? Yeah. So the question is, like, if you are going to be doing a cataract surgery in these patients, so if it's a case of recurrent herpes infection, you wait for the eye to be quiet for 6 months, but would you start prophylactic oral antivirals for all these patients? And what would be the regime?
Yeah, I personally prefer to start because quite often steroids is also one of the trigger factors for recurrence of HSV epithelial. So if we are planning a surgery, personally, like if I know the patient scheduled for a surgery, I start a week prior, or at least if not started prior, at least in the peri-operative, I'll give the prophylactic dosing. Dr. Revati Madam can give her thoughts on that. I think it is better to give because quite often steroids can lead to, we've seen quite many patients have an epithelial recurrence in the post-operative period.
Yeah. When we know that the scar is due to the viral keratitis, yes, of course, it's better to start. Usually we prefer to start about 2 weeks before and continue as long as we are giving steroid in the post-operative period.
If a patient has had no recurrence at all for 1 year, would you consider refractive surgery in these patients at all? And if at all, then PRK or flap?
I won't consider refractive in these patients at all.
Madam, now with the widespread availability of valsiclovir, what are your indications, or when do you switch between valsiclovir and acyclovir, or do you prefer only valsiclovir now?
I generally prefer valsiclovir because I see even well tolerated, even with acyclovir, some of them complaining gastritis and very rarely liver enzymes going up, though it is not documented in the literature. And valsiclovir I prefer. And also the dosage is easier for the patient to follow. Just once a day.
Once a day.
So many of them are, once a day. Prophylactic dose is only once a day.
Yes.
I think it's been a very long session. So there's any number of questions we could ask Dr. Revati and with Dr. Sunita here. So thank you so much. I think I wish I had said this thank you while many more people were there. I'm telling you all right there when just few of you all are there. But thanks so much for making this eye education webinar so intensely useful for all the people who have watched. And I think all of us have also learned a lot in the last 2.5 hours. So truly thankful, and I look forward to taking your help again whenever the time comes up. Thank you so much. Shreyash, you have anything to add?
I really, I think we've had some really experienced and outstanding set of speakers, and we've learned a lot from this evening's program. I think the involvement of the entire panel, expert panel, along with the speakers in providing so many various inputs, I think has been invaluable. Thank you so much, everyone, for having joined us and been a part of this program.
Thank you. Thank you. Good night.
Thank you,
Good night.
Appreciate it. Nice program.
Thank you, madam.
Thank you.
Thank you so much.